Welcome to our webinar today, and to all the people joining us from across the globe. Our topic for today is how we can support health systems that are under attack, including in Palestine and Syria. And I would like to start by offering an acknowledgement of country. For those of you who are not in Australia, this is something that we do to acknowledge the Aboriginal and Torres Strait Islander peoples of Australia. But I would like to say that as a settler in Australia, it's not just for me to stand against settler colonialism in Palestine without acknowledging that these same processes continue here in so-called Australia. So as I speak, I stand on the unceded lands of the Bedigal people, people whose connection to this land stretches back many tens of thousands of years. And that connection to the land, the sea, and all beings that are part of country is one that's built on reciprocity, care, and respect, rather than ownership, extraction, and control. And so I suggest that to learn to respect and care for country might bring us all closer to liberation in this land, which always was and always will be Aboriginal land. Similarly, when we say from the river to the sea, Palestine will be free, the world is offered an opportunity for a society where all are treated as equal, from the Jordan River, across the olive groves and the holy sites to the Mediterranean Sea. So it is with liberation in mind that we turn to today's topic. And I would like to bring everyone's attention to the interpreting function that we have on today's webinar. So you should be able to choose to listen to our presentations in either English or Arabic by using the interpretation function at the bottom of the screen. So our topic for today is how do communities resist colonization and oppression through caring for one another? Health workers are dedicated to caring for others. This is a radical act, one which aims to liberate others, and that's why they are so intent on destroying healthcare. Attacks on healthcare are not a new thing. In addition to the almost 500 healthcare workers that have been killed by Israel since October last year, healthcare in Palestine has been under attack for many years. In Syria, attacks on healthcare have been a part of an attempt to undermine the revolution since it began. Since 2011, Physicians for Human Rights have documented 948 health workers have been killed. Many mental health practitioners were arrested and tortured simply for doing their job of trying to care for others in their communities. This shows us that care is a radical act of resistance that frightens the oppressors. So today we will listen together about how do we do that resistance from within those settings, but also from afar, and how do we show solidarity. We have 14 speakers from, I think, about 5 different countries. First up, we will hear from Guido Veronese on the agency and activism of Palestinian children. Then after a short break, we'll have a panel on how to keep health systems running when they are under attack by violent regimes. We will hear from 4 Palestinian and 2 Syrian mental health experts on this topic. This will be followed by a break where we will then have 2 sessions where you can choose between the 2 sessions, and I will explain those to you later. But I will start now by handing over to Guido. Guido is a clinical psychologist from Milan who's come to visit us all this way. He's an individual, marital, and family systemic psychotherapist, and he has a long-term connection to the people of Gaza, including teaching at the university there. His solidarity with the people of Palestine is in evidence today, as all of the Palestinian speakers have come to speak at his invitation. To me, this suggests a deep trust that can only be developed through long-term, authentic connection. So I think no more introduction is needed, and I welcome Guido to speak.
Thank you very much for having me. Let's try to handle my slides now. Okay. Thank you, finally. Yeah. Let me share it on Zoom. I have some problem. Ah, okay, no. Yeah. Okay, this one. Sure. And now I can see from here. Yeah, already. Yeah, now it's here. So thank you for having me. Let me introduce myself briefly and about myself. I used to teach in Gaza since the beginning of the war. I've been there just 1 week before the beginning of this massacre. I used to teach at the university, doing supervision to social worker and family therapist, working on research. So really, the main part of my research and teaching work was there in Gaza. So let me say that this moment is a very sensitive moment, even for my emotional stability and my mental health in a way. Everything changed in my life after the war started. The most part of my work have been focused mainly regarding research on working with children, working with mental health providers that are involved in child protection and child work. And the most part of my research activity was and is still going and see which functioning factors, how children continue to show and develop skill of survival, so despite the condition of war and severe violence and violation of their rights. Let me start with a very brief and short clip, which is part of a 2009 documentary by V.K. Lockenberg, and that is showing and focusing on how do I mean when we talk about functioning despite so severe condition of violence and sorrow. Children are navigating, children in Palestine are navigating and continuously switching from this feeling of hope, feeling of thinking of their life in the future as a proper and good life, and despair, sorrow, sense of hopelessness and powerlessness. And if you listen to this very short clip, you can clearly perceive what I do mean.
مستشهد أبويا لواحد كأنه فقد كل 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 إخواته كل قرايبه، كأن حدا عنده في الدنيا كلها. لما فقدنا أبونا فقدنا الأمل، فقدنا كل إشي بحياتنا في الإنسان. لما الواحد يفقد أبوه يصير يعيط بالليل، يصير يتذكر ويعيط. كنت متذكر أعيط بالليل، كنت أعيط. احنا ما كنا دكتور عشان نعالج المرضى اللي بالصوابع من اليهود وعشان نعالج وأدوية ودواء وأعمل عمليات للي بدنا نعمل عملية اللي بياكل مثلا طلق أو شظية بعمل له عمليات.
So this kid is talking about his despair, the fact that he lost his father, the fact that in the night he's dreaming his father and is completely despaired by the loss of a so important figure in his life. And this is the condition of a great part of the Palestinian childhood in Gaza. On the other side, you listen to normal dreams for the futures by children. He wants to be a doctor. He wants to grow up and study. But when you are talking about Palestinian children, these very normal act and normal feelings for their future are taking a totally different meanings. This meaning is a meaning of resistance, is a meaning of being part of a community that want to, in a way, push back and fight back this sense of oppression and this systematic violence that are oppressing them. So thinking of your future as a student, thinking of your future as a worker for a Palestinian children means act for resisting and existing. And let me just talk about myself and quite a sense of contradiction when I talk and I speak about my research in Gaza with children. Even taking some consideration about the consequences of my work there as a white male and a Western researcher and psychotherapist. Here I am during the Great March of Return. I was visiting a group of children and the youth, asking them why do you demonstrate, why you think is worth in your life to make your life at risk, and going to this demonstration having at least the opportunity to be disabled by Israeli snipers. And the answer of certain of them were simply because I want to die. I'm not interested in continuing my life anymore. That was very shocking for me, and that was a way to make me reason about the sense of my work there in Gaza. Nowadays, if I consider how my data, the data that I provided as a Western researcher has been used, I cannot say that this was a benefit for the children. I cannot say that that was usable and useful for children that then could have their rights respected. They could have their life again restituted to their right childhood. The most of my work, the most of the data I provided nowadays, I have the proof have been used to strategically and systematically target those children. So you will see during my presentation how we were so good in shaping the competencies of resistance and resilience of these kids, and how the technologies of war and violence used this data to systematically destroy such competencies. So when I enter Gaza through this tunnel, this 2 kilometers long cage that is making you enter in the so-called hell of Gaza. This is the definition by my friends when I enter. Welcome to the hell. It's the opportunity to reflect and to think how much my way to be there, even as a researcher, can be part of a necropolitic that is destroying the indigenous, the local opportunities to develop and to grow in terms of knowledge, in terms of freedom, in terms of competence. nowadays, I cannot say that I'm satisfied about the results, but I'm still here talking about my work. And here, before starting, let me acknowledge the two people who are the one that most helped me in collecting data and in being in touch with these children in Gaza. The first one is La Jarada, he's a psychologist. He lost his home and his oldest son, Malik, at least 1 month ago. He's totally desperate. And the second one is a Candy, a beautiful man, a beautiful soul, Shaher Yagi. He was the representative of the United Nations Relief Work Agency for the disabled children. And he died under the rubble of his home together with his 4th son a couple of months ago. So let me say I don't have any more field workers cooperating with me in Gaza right now. Or just I have one who lost his son and his home. Here the figures, at least 14,000 children has been killed right now. The most majority of the casualties right now in Gaza are of civilians, while a very small part is about the so-called terrorists or fighters, as you want to consider that. And here, why I think the consequences of war against children are not collateral effects, but are strategic and detailed and precise technologies to target, to destroy the most powerful and functioning part of a society. And this is not just about Gaza, it's in general during the war. Children are not collateral effects. They are targeted because they are the symbol of the functioning of a society. Destroying children, you can annihilate your enemy. As I told you, showing the very short clip at the very beginning, every act of existence, every act of performative competence in moving in their space, in their places for children in Palestine is an act of resistance, is an act of being part as a situated social actors of a community that want to resist to an ongoing structural violence. And what happened once our methods, our models, our theories are working in trying to help children affected by war and violence? Using this definition by Boyden, the risk is to psychiatrize the resistance. The fact that you focus just on the consequences in terms of psychological impairments, in terms of psychological burdens of those children involved in war, is a way to totally neglect the part which is the part of children that are resisting, are continuing to function despite the horrible condition they are forced in. Our Western models are very much focusing on the post-traumatic consequences of potentially traumatic events and are making children like passive and incapable to handle their life despite these horrible conditions when they are facing with war and violence. On the other side, and I can say that my work is inserted in this way to consider the functioning of children during war and violence. There are a few number of studies that want to focus on competencies, on capabilities, on the ways children every day are using in order to counter-react to these structures that are oppressing them. Let me show you a part of our research. We will then we'll go back later when we listen to children that become a kind of a guide in the refugee camp, guiding the researchers and the psychologists all along the alleys and the places of their spaces and places, and describing their lives. And you can perceive as every act of these children is an act of resistance.
إذا أنت ملاحظة إنه أنا بس أطراف المخيم، يعني إنه بس شروق وجنب شروق، وهون يعني مش دائما، يعني ما بننزل، مرة نزلناها وندمنا لأنه كثير زبالة وكثير بدخل فيها الجيش.
Here we are in West Bank.
لما نشوف المخيم بنحب ندبك، لأنه هو اللي بعطينا دافعية إن ندبك، لأننا نقاوم. نقاوم مش بس بالحجر، كمان في الدبكة. In this camp, the women they don't have anything. No parking, no internet, no coffee shop. وكانوا الناس يجوا يرسموا ويعبروا عن الحزن وعن قديش إن فلسطين مهمة. الحين أنا يمكن بس مرتين لثلاث رحت فين على القدس. أول مرة رحت فيها حسيت إنه قديش صعب إني أروح على القدس، إني أتفتش لما أروح على المدينة اللي يعني هي إلي مش إلهم.
So even in this very small clip is showing as every act that is in a way characterizing the life of every child all over the world in Palestine turning in an act of resistance. So moving in the spaces, dancing, playing is a way to perform and to claim the right to resist in an occupied landscape. Here some theoretical, but I want to skip this part quite quickly. The fact that the theoretical backgrounds that most are focusing on what we call functioning factors are related to this concept of resilience. The concept of resilience that has been strongly criticized by indigenous scholars, both in Palestine, but even in other contexts, because even in this case, first, the concept of resilience is still a very Western informed concept. And then again, it seems a concept that risks to passivize people. Is the fact that you are under condition of suffering that could make you develop possibly symptoms, but as for different factors, individual and contextual, you will not develop those impairments. Studying and being part of the Palestinian context, I realized that the concept of resistance is much more connected with their experience. They are not just resilience, they are actively operating in a way to push back this sense of oppression and sense of suffering, which is characterizing their societies. So let's say that we are quite into these ideas of resilience, but it's not completely satisfactory. And then another concept we were, of course, analyzing is the concept of well-being, subjective and objective well-being, which is very belonging to tradition of positive psychology and are making us in the direction to think more on functioning factors rather than dysfunctioning factors. Here, another act of resistance. Study is not just studying, but in Gaza, is I claim my right for studying. Here, the conceptual model we are working on since a decade, the fact that through life satisfaction, if the more children are satisfied because of their lives, the more the children are capable to be in touch with a sense of satisfaction of daily life, the more they are capable to use strategies to control the symptoms of trauma. And the concept of agency were helping us in thinking of an activator of life satisfaction. What is making children activate their life satisfaction? The capability of children to act. We will enter now in the definition of agency, but the best definition to me is agency is the human competence of acting. So here the definitions that we used. Let me say that the most satisfactory definition I found during my work is the competence of agencies as a competence of children to actively act and counter-react to structures of power that are oppressing them. And here, quickly, the results of our research. What we found in our quantitative study is that the life satisfaction of children was capable to control the symptoms of trauma. The more the children were satisfied, the more they were capable to decrease the symptoms of their trauma. And then here, we found that agency was an activator of life satisfaction. What is interesting, and this is exactly the point of why agency is, by definition, simply a competence is to act, is that if life satisfaction was not implied in this conceptual model, if agency was acting directly on the symptoms of trauma, the trauma was not decreasing, was increasing. So we found that life satisfaction was the real mediator of between agency and the symptoms of trauma. The fact that the children are actively engaged in activating their life satisfaction were reducing then the symptoms of trauma. Then we entered very quickly in the qualitative part of our work, and exactly we found the different dimensions that nowadays are systematically targeted by the war and by the occupation to try to destroy their competencies and their ability. So life satisfaction was declined by children in a satisfaction about their environment, how they actively were capable to transform, even with a very simple act, their surrounding in environments that can be satisfactory for them. So just changing a small playground in the refugee camp, or drawing in their schools, or transforming in a way their surroundings to make them more satisfactory. And the peer relation, the fact to be capable to feel a positive emotion, their family, their way to play, the way to feel themselves proud and satisfied about themselves, the satisfaction for their sociality and community, and the health and school and spirituality. Mosques are bombed, schools are destroyed, the health system completely disrupted, the sociality totally impossible. Did you see how families were separated from the north to the south? Children cannot fulfill their idea of realize their dreams in their lives. Impossible to play. The family has been completely destroyed, and the emotional world of the kids completely disrupted. The environment of Gaza became unlivable. And then impossible to realize sufficient and life in dignity. So just to conclude, I want to conclude with some of the excerpts that we took from the interviews to these kids that is making us understanding how the structures of power are systematically targeting them. Living in Gaza is so difficult. After the last war, I lost all my favorite belongings, my rings and toys that my parents had given me. I am as beautiful as the moon. What should we do? Tell me what you have to try to enjoy yourself by playing or reading or watching TV. And then an example of life satisfaction through activism and representing the Palestinian struggle. I feel happy when I can join demonstration to protest against what the Israelis are doing to us. We chant for freedom and justice, and we show the world how the Israeli soldiers want to kill us. I like the Palestinian flag and demonstrating with my father against the Israeli occupation. Thank you.
Thank you so much, Guido, for such a touching presentation and one which focuses on resistance of those children and the lives they're trying to build and live. I'm wondering if there are any questions. Are there any? If anyone wants to post a question in the Q&A, if you have a question for Guido, if you like, perhaps we can see whether there are questions at the end of the whole session. Okay. Yeah. All right. Oh, sorry. I wasn't looking at the people in the room.
Thank you very much for this presentation. Million different questions one can ask, but my question will be about, in giving the last slide that you've used, the two last slides that you've showed us, about the day after. None of the factors that you've highlighted as compromising children's resistance is going to change. Family separation, destruction of healthcare system, nowhere to play, the eradication of schools and families, children losing their family members, their relatives, their friends. This is not going to change even when the fighting will stop. What's the trajectory then with respect to recovering from this trauma and regaining their capabilities and resuming their agency and resistance?
Thank you. It's very difficult to answer this question. Let me say that this is recognized by the Palestinians themselves as one of the, let me say, the most terrible and destructive events since the beginning of the Palestinian suffering in the 48. So predicting what will happen next is very, very, very difficult. Let me say that at the moment we can at least consider 3-4 levels of trauma, which are making the Palestinian experience very, very unique and complex. A collective suffering is the fact that it's not just suffering of individuals, so not just the children suffering, but is the whole Palestinian social suffering that is in a way contributing even to the individual reactions. The fact that we are experiencing an ongoing and continuous traumatic experience, the suffering is continuous, and we don't see an end. We don't see a post. We don't see what could in a way mitigate such a kind of suffering, even taking into consideration that, okay, this is a very incredible and unexpected magnitude of suffering, but the children's suffering started very long before the October 7th. And then the colonial trauma, the fact that the Palestinian suffering is made of a sense of oppression, dispossession, loss of identity, of memory, which is related to a strategic and continuous attempt by the colonizer to disrupt the Palestinian identity. And the historical trauma and transgenerational trauma is a trauma which is transferred from generation to generation. So really the complexity is so enormous that it's really so difficult to think of a positive future for the Palestinian children. What can make me, as a Palestinian writer, call it pessimistic? This is the condition of the Palestinians, to be pessimistic and at the same time optimistic. This is their story. So we can even imagine the unexpected, something that we think is of a magnitude that will make anybody capable to react to this. Maybe for the Palestinian will be quite different. This generation and ages of suffering are made of very small things that are shaped by beauty, mutual decency, love, family connection, that we will see if we'll continue to work in the so-called Palestinian sumud, steadfastness, capability to stay steadfast in front of what is unimaginable in terms of violence and trauma. So I know that this is not an answer, because really these events made us totally shocked, and we don't know what will happen next. But we will see if the Palestinian resistance will continue despite this incredible and never seen violence against them.
Thank you so much. Thank you so much. I see that we have a few more questions, and also that we've had a bit of a gap in the interpreting, but my understanding is that it is back up now. I would like to move on to the panel, because we have a lot of people who have phoned in from many places. So perhaps we can move on. And if you still have questions, please feel free to place them in the Q&A chat, and we can try to address them later. But I will move on now to the panel presentation, which will be focused on hearing from health practitioners and activists who are joining us from Palestine, and also from the diaspora, and from Syria, and also from the diaspora as well. And this panel will be focusing on how can we support running health services under siege in these settings? What can we learn from the resistance of these practitioners? And I'd also like to really express my gratitude to all of the presenters for coming to speak today, because I know that it's not an easy topic to talk about, and that this is more than work to you. These are your families and your communities. And so just to pay my respect for the fact that you are doing this today. And I think also, if we're talking about this topic of what's needed to support health in these communities, of course, stopping the bombing, ending the occupation, and ending the siege is what we need. Until we have those, it's great to hear from you about what you would like to share about how we can work together in solidarity to keep supporting these systems. So I'm going to introduce the speakers one by one. You will each have 5 minutes to talk, and I will put my hand up on the hand up function to let you know when you've got a minute left. And then hopefully at the end, we will have some time to all talk together and field questions and have a collaborative discussion. So I hope you can all bear with us. We've got a lot of technology going on here. So hopefully we might have some waiting, but hopefully it will go smoothly. So the first person that I would like to invite to speak is Dr. Mohammed At-Tawil, who's the founder and director of the Palestine Trauma Center in Gaza and also in the UK. Dr. Mohammed, can you let us know if you can hear us and are able to jump on? I think we don't have Dr. Mohammed yet. So perhaps we will hand over instead to Naman Libda, who is a medical doctor from Gaza. Naman, would you like to join us?
Yes. Hi, everyone. Should I start now? Yeah. Let me share. Okay. Can you see the slides? Okay. Should I start? What should I do? Okay. I am Nermina Bulabda. I will be talking about mental health services in Gaza Strip under violent destruction. So this information I have obtained after talking with my friends in Gaza Community Mental Health Program and the Ministry of Health. I'll be organizing the topics into manpower, means, and the economics and management related to the mental health services in Gaza. Each one of them will be talking about the challenges and solutions. But first and foremost, we should talk about the types of mental health services that are providing at this moment. There is medical treatment, psychological first aid and support, psychoeducation, and toll-free telephone counseling, which is very specific for Gaza Community Mental Health Program. There are some also psychotherapy sessions that is provided by the Ministry of Health. And last but not least, trainings that is provided by Gaza Community Mental Health Program for humanitarian aid workers on psychological first aid. Starting with the first aspect, the manpower, there are many challenges that the staff are facing at this moment because, as you may know, mental health workers are also human and they are also victims of this ongoing genocide. They are displaced, they are lacking of the stable living condition and so on. So this would affect the continuity and the quality of care they are providing. They are also worried about their families. They are also worried about their safety, their own safety in this war. And last but not least, some of these experienced staff have left Gaza seeking for safety. Some of these solutions that Ministry of Health and Gaza Community Mental Health Program that have implemented to face these challenges are providing caring sessions for workers and helping the staff to obtain living essentials. Ministry of Health has been assisting the staff to obtain somehow to ease the process to obtain cooking gas, food parcels, and so on. However, one thing that would help the staff at this moment is have more delegations and experts in the field of mental health. Ever since the beginning of this war, psychiatrist has entered Gaza in the past 100 days. And last but not least, remote jobs has been offered at this moment. The experienced staff are working remotely and adapting their jobs. The second aspect we will be talking about the means, the knowledge and commodity and the challenges related to them. As mentioned before, it is not safe in Gaza and there is absence of easy and safe, cheap transportation to and from the war. So Gaza Community Mental Health Program fixed this issue by providing designated transportation for their staff. However, Ministry of Health wasn't able to address this issue at all at this moment. Gaza Mental Health Program has adopted the approach of mobile clinics in the displacement camp. So this would ease the transportation for clients and the working staff. And there is another problem that's going on at this moment. Another challenge is the discontinuity of the telecommunication services. So Gaza Community Mental Health Program are currently collaborating with Palestinian therapists outside of Gaza Strip provide telephone counseling services to ease this process, to ensure the continuity of the service. One of the major problems at this moment is the severe shortage in psychiatrist medications. Gaza Mental Health Program is doing much better than Ministry of Health in this section. They have been collaborating with international NGOs, and they have been offered some of these. Medications, not in sufficient quantity, but it is better than the Ministry of Health. And sadly, the Ministry of Health staff had to ask people who are delegations who are entering Gaza to smuggle some of these medications in small quantities so they can give it to the patients. And last but not least, there are no professional training at this moment for mental health workers. Gaza Community Mental Health Program has evaded this challenge by providing supportive supervisions and discussions between the mental health workers. The other issue that is happening with the facilities is the demolishing and the destruction for these facilities by the Israeli occupation forces. The only psychiatrist hospital in Gaza Strip is demolished. There is no inpatient treatment at all for any psychiatrist patient at this moment. And most of these Gaza Community Mental Health Program and Ministry of Health are operating in small rooms that there is no privacy for consultation and so on. And last but not least, it is not safe to work at any place in Gaza because of the Israeli occupation forces. The current solution, the applied solutions for these are, they have rented some of the temporary places to operate in it, and they would love to, practitioners, they would love to have a designated room or designated tent only for consultation that would provide the privacy. And surprisingly, Ministry of Health had to cut off the working load, the working staff to only include the experienced staff so they can minimize the crowdedness in this room. And last but not least, Israeli occupation forces should respect international humanitarian law so they can provide safety for these workers. And regarding the management, unfortunately, there was a delay in response, especially for Gaza Community Mental Health Program. They have resumed providing services only in February 2024, 4 months after the beginning of this aggression, which is very delayed, understandable at this moment because the staff themselves were displaced, the staff themselves were facing many atrocities. And there is another challenge is the fragmentation of the services, the lack of awareness of the service providers themselves about other service providers, what they provide, what they provide, their capabilities, and so on. There is lack of coordination between these service providers, and there is lack of incentives for the staff. And last but not least, there is difficulty in documentation and making informed decision making, and that is very understandable at this moment because it is very dynamic and very changing environment at this moment. Me myself, I had been displaced 4 times during this war, so what we collect data at this moment can be applied in the next one. So some of the suggested solution for these problems would have been if there was an emergency response protocol to use and implement that would minimize the delay in the service provision. It would have much better if there was more incentives for the staff, more motivation, more recognition, and more financial incentives, especially because of the hard living conditions because of the very expensive stuff that you can buy at this moment because of the siege, unfortunately. And we can absolutely benefit from fostering collaboration and communication between services. And this could be done by mental health cluster, which is present at this moment. But I don't know what we can do about it. It's not fully operating at this moment. And last but not least, the challenges related to economics and money. Mainly the mental health sector in Gaza Strip is relying on donations, and donations have absolutely shifted from the mental health services to other necessary things, just like shelters, food, and other necessities. And this made just a huge gap. And last but not least, Ministry of Health cannot provide salaries for its employees. for its employees. And as mentioned before, life is more expensive than before. And this could be done, solved by advocating more for financing mental health services in work context, more collaboration between international NGOs and other service providers. We can minimize the duplication, minimize the waste effort, and the other things. So I hope this was clear. Thank you. Do you have any questions?
Everyone in the room is clapping. Thank you so much, Nermin, for, I guess, showing us the amazing ways that people are responding, finding ways to keep things going and being so flexible. So it's really great to hear that kind of system level approach. I wonder if it would be good to hear from each of the panelists, and then maybe we can have a question and discussion after that. So maybe I will move on to hearing from the next person, which is Abdul Rahman Al-Muqayyad. Is he there with you, Nermin? Is that right?
He's my husband, but he's in another room. He will start now.
Okay, perfect. Well, Abed, we welcome you. Can you hear us, Abed?
Yes, can you hear me?
Perfect. I'll let you know when the time is up. Thank you so much.
I'm sorry that my webcam is down there, so I will be looking at the screen most of the time. I want just to share my screen very quick. Okay.
Abed, your sound is not very clear, so maybe try to go right into the microphone.
Hey, what about now? Can you hear me good right now? So hello everyone. My name is Abdul Rahman. I worked with MSF for the past 2 years as digital health and promotion officer, where we do like promotion and campaign using digital tools like Facebook and Instagram. I will talk to you about how MSF worked through this war like the mental health support that they have. But just to be clear, I'm not like representing MSF in any way, shape, or form. I'm just an employer who have some observations that wanted to share. So just keep that in mind. So MSF started like their mental health programs 2 years after the war has started, which is understandably a little bit late because the nature of the conflict and the continuous displacement that happened during this war was very severe on everyone. So they started after the first truce in December, and they started with a small team of one person, one psychologist, and then they grew up to have like 3 clinics, 8 psychologists, 2 counselors, and 1 doctor currently. And their approach was very interesting, that they prioritized the psychological first aid and single session approach. So usually when they sat with patients, they did not have like a proper diagnosis for each patient. And so is the sound problem still going? Something okay.
It's quite hard to hear. Maybe you could go close to the microphone, or maybe use the microphone in the other room.
Okay, I might do that. So just
we're all so used to having these problems with technology. It's great to be connected, even though it's hard. We can't hear you right now. Why don't we take a moment while that sound issue gets fixed and see if anyone has any questions related to Nerman's presentation or comments.
So can you hear me now? I think that is better. I know I'm talking from the other microphone.
That is beautiful.
Yes,
Please
thank you.
speak slowly and clearly in here. Thank you.
Yes, yes. So as I was saying about MSF efforts, they usually the main focus was them is using single sessions for each patient. So what they were doing is that they focus on the symptoms that the patient is presenting with, and then dealing with it and equipping them with whatever information they can provide, because they're not sure that they will see this patient again. Also, they were just handing some prescribed drugs for patients with chronic conditions, and many educational group sessions that they were having. One of the challenges that MSF has suffered from is letting people know that their service is even available. So they're promoting their services, but it's very difficult because again, the continuous displacement has made many mobile clinic happening at the same times. So people did not know, even like for myself, when I had one of my relatives who wanted to seek help, they did not know where to go. Also, like most of the areas in Gaza, like the north of Gaza and middle area were not covered because of the war condition there. They were only allowed to work in the safest places, but that like wasn't where most people were located. Can you go next, please? So when we ask how to keep the system running, I would look at MSF and look at the positive and the negative part of what MSF did. Next, Nermeen. And one of the main positive part for myself looking at the situation is that you need to really invest in your employers, and that's what the MSF did. They give very good incentive for their employers, not only like increasing the salary, but also they provided shelter for the families of the employers, and they provided transportation. Also, can you go next, Nermeen? We did a lot of assessment, meaning that we went, again, next, we went into most of the common camps that happened in Gaza, like in Rafah, and we identified exactly what people need and what is the most neglected areas. So you can prioritize and like look where do you want your focus to be. For the negative part, next, Nermeen, I would say that there are a lot of fragmented effort between the organization here in Gaza that me and MSF was like working in isolation to other organizations like MOH and other organizations. So like many of the effort that MSF was providing was not even known by other organizations and by people. And from my personal experience, there's a lot of more effort that can be done that haven't been done, not only because of the focus of mental health is a bit neglected. Like there are a lot of people that works remotely, like WeConnect, WeConnect was an initiative that happened outside of Gaza, where they connected people online with therapists that they are affected. Can you go next? So I would say, like, if you look from your point of view, the people who are outside of Gaza, how can they support the mental health systems, and how can they support the people of Gaza? And I have like maybe going to know that I have lost my entire family at the start of this war. Like 14 days after the war, there was a bombing that happened to the place where my family were sitting, and 8 members of my immediate family have died. And the main thing that affected me more than their death actually is what it was like the amount of negligence and the amount of inconsideration from the world around us, from like the government and people on Twitter, and how inconsiderate they were. And I think that the colonial system that is currently running have been set up for many, many years, and it's very organized effort to oppress people like us and other people in oppressed areas. So go next, Nermeen. I would say that the main effort that any individual person can do, so this is like the photos of my family, go next to me. The main effort that any person can do is to unionize, meaning that any individual effort, when compared to the behemoth of the colonial project that happened around the world and the empires that have been created, is very minuscule. But you can start small by unionizing wherever you are to pressure the people in power to change their aspects. Like if you are a psychologist living in Australia, doing a webinar like this is very good area, like inviting people around you. Because if you think to yourself and you only publish on Twitter, you won't accomplish much. And not only like in the psychologist, if you are a student, like the student protest that beautifully happening now in America, it only happened because some small percentage of people try to level their voices by uniting each other, and the whole world listened about them. If you are working in a media coverage program, or if you are in a company, do the unionizing and pressure people in power with whatever you want to happen in this world. Next, and thank you.
Thank you so much, Abdurrahman. Those are very encouraging words, because from afar, it can feel like there's so little that we can do. But joining your union, and everyone out there, if you're an academic, NTEU, if you're not a member, why? Get on there. So yes, join your union, come together. Thank you for bringing this up and for sharing your experience with us. Okay, let's hear. I'm just wondering whether Dr. Mohammed Atawil has joined. Okay, why don't we go on to here. Is Dr. Amar there? Okay, why don't we go on to hear from Ala Al-Ali, who is a fantastic psychologist joining us from Syria, who works with an organization called OSAM, and they've been doing fantastic work for a long time, coordinating the efforts in Northwest Syria. So please, Allah.
صباح الخير. صباح الخير جميعا، ومرحبا بكم. شكرا روز للمشاركة. أنا علاء العلي، ماجستير، طالب ماجستير علم نفس عيادي ومشرف تقني في مشفى الأمراض العقلية والنفسية بمنظمة أوسوم. أنا أتحدث عن تجربتي كمقدم خدمة بمجال قطاع الصحة النفسي وشخص متضرر يعني في شمال غرب سوريا من الحروب اللي دامت مستمرة لأكثر من 14 سنة. نحن نعاني من هذه الظروف الصعبة. راح أتحدث عن تجربتي في قطاع الصحة النفسية، كيف تم العمل لدعم هذا القطاع على الرغم من الإمكانيات الضعيفة. بداية عملي أو مسيرتي في دعم قضايا الصحة النفسية هي كانت بعام 2012 أثناء اشتداد النزاع أو الصراع في سوريا وازدياد عمليات التدمير والقتل والتهجير. ما هو معروف، حرص النظام السوري وحلفائه على كيف استهداف البنى التحتية بشكل ممنهج، سبب ذلك بتعطل كبير بمنظومة أو القطاع الصحي بشكل كبير، إضافة ل آلاف القتل والتهجير من القتل العاملين بمجال الصحة النفسية. هذا الشيء أدى إلى هجرة الكفاءات والتخصصات خارج سوريا هربا طبعا من الموت. هذا الأمر فاقم هذا الصراع اللي بشكل عام هذه المشكلة لدرجة كبيرة، أثر على القطاع الصحي وأثر على العاملين في مجال القطاع الصحي. كان له تداعيات كثيرة على الأشخاص، على الناس اللي هن في شمال غرب سوريا نتيجة هذا التدمير، نتيجة هذا القتل الممنهج، ظهور الكثير من الاضطرابات النفسية مع فقر بعدم وجود تدمير القطاع الصحي. بداية لدعم هذا القطاع الصحي كان هي استجابة المنظمات الدولية المحلية المدنية من خلال تسليط الضوء على أهمية الصحة النفسية في هذه الظروف الصعبة واشتداد الزيادة في حالات الاضطراب النفسي وحالات الانتحار نتيجة هذا القتل والتدمير. خلال تلك الفترة البوصلة ما كانت واضحة كيف راح يتم دعم هذا القطاع الصحي. كان عمل بشكل غير ممنهج بعمل يعني لسد هاي الفجوات. أول دعم كان من منظمة الصحة العالمية اللي هي لممنهجة العمل، قامت بإطلاق دليل معياري كتدريب للعاملين بمجال الصحة النفسية، استهدفت فيه الأطباء العام، تدريب مجموعة من الأطباء لرأب فجوة، دليل رأب الفجوة اللي هو يتعامل مع الاضطرابات النفسية الأكثر شيوعا. وأطلقت دليل معيار أيضا للعاملين في مجال الصحة النفسية اللي هن ضمن مسمى العمال الصحة النفسيين اللي هن غير مختصين، لكن لسد هاي الفجوة نتيجة ازدياد في الحالات أو الاضطرابات النفسية. توفير الدليل للعاملين النفسيين الاجتماعيين لمجموعة لأكثر من 120 عامل في مجال الصحة النفسية. شارك بتأسيس هذا الدليل هو مجموعة من الأخصائيين النفسيين السوريين سواء من داخل شمال غرب سوريا أو موجودين في تركيا لضمان موائمة هذا الدليل مع السياق السوري. أنا كنت أحد المشاركين بنقل هذا التدريب في شمال غرب سوريا من خلال التدريب والإشراف على هذا الدليل. في عام 2017 مع وجود ازدياد حالات القتل والتدمير كان في عدد من يعني عدد من في حاجة لأنه حاجة لهؤلاء الأخصائيين النفسيين وحاجة لمراكز لدعم قطاع الصحة النفسي. فتم بعام 2017 نتيجة هذه الحاجة لدعم القطاع الصحي بتأسيس أول وحدة أو أول مشفى بالأمراض العقلية والنفسية اللي هي كانت في شمال سوريا بمنطقة تسمى سرمدة. أيضا كانت بدعم من منظمة الصحة العالمية بالشراكة مع المنظمة اللي أنا أعمل فيها هي أوسوم. سبق هذه الوحدة مجموعة من التحضيرات والتجهيزات لتأسيس هذه الوحدة وتصميم أنشطة لتكون هي أول مشفى يقدم الخدمات السريرية التخصصية بالمستوى الهرم الرابع لبقعة جغرافية تحتوي على أكثر من 4 ملايين شخص عانى الويلات من ظروف الحرب. بعد فترة أيضا تم إطلاق عيادات نفسية نقالة لدعم القطاع الصحي. هذه العيادات النفسية مؤلفة من طبيب وعامل نفسي اجتماعي وكادر صحي بيخدم المناطق الجغرافية اللي لا يوجد فيها مراكز صحية. أيضا مع مرور الوقت ودعم القطاع الصحي تم تأسيس وحدة أخرى في منطقة جغرافية تبعد عن إدلب وهي موجودة بريف حلب ب 170 كيلومتر، اللي أيضا مشفى أخرى حاجة إنه زيادة الحاجات بريف حلب. تم إنشاء مشفى للأمراض العقلية والنفسية سعيا لحتى انه مساعده الاشخاص اللي هنا عدم وجود خدمات او قطاع صحي مدمر نتيجه الاستهداف الممنهج من النظام، وحرصا دائما ان نرصد الحاجه التي نراها على ارض الواقع ونسعى تلبيتها. تدريب ايضا الكوادر واشراف على هذه الكوادر لتقديم أفضل الخدمات اللي هن الأشخاص اللي هن محتاجين في قطاع الصحي. كان التدريب على أكثر الاضطرابات شيوعيا، اضطراب ما بعد الصدمة عند الأطفال، أيضا حالات ازدياد حالات الانتحار، تم تدريب على الحالات الانتحار، إطلاق الخط الاستجابة الطارئة، الخط الساخن للاستجابة لحالات الانتحار. ضمان السعي المستمر لتطوير والتأهيل تم اقتراح أيضا بعام 2023 بالشراكة مع الاتحاد الأوروبي لدعم القطاع الصحي بأخصائيين بالطب النفسي. حاليا يتم تدريب أطباء نفسيين بالشراكة مع الاتحاد الأوروبي، وتدريب في مجال علم النفس السريري، اللي أنا حاليا شخص يعني أدرس بمجال علم النفس السريري، وأيضا تأهيل تدريب بالممرضين النفسيين. هذه التدريبات النوعية والتخصصية كلها عم تصب في دعم القطاع الصحي، بالإضافة تم تدريب مجموعة من الأخصائيين النفسيين ضمن برنامج العلاج المعرفي السلوكي عن طريق منح من طريق منح الاتحاد الأوروبي لمنظمة الأوسم. هو 42 أخصائي نفسي حاليا يتم إطلاق بالميدان للتعامل مع هذه الحالات، اللي الحالات فعلا تفاقمت نتيجة الاشتداد الصراع. هلا أنا ما راح أطول كثير لضيق الوقت. أنا راح نلخص تجربتنا نحن يعني كتجربة في شمال غرب سوريا، كيف حافظنا على النظام الصحي. لأن الخطوة الأولى دائما كان الانطلاق والتركيز على استثمار في الطاقات البشرية الموجودة في شمال غرب سوريا من خلال التأهيل والتدريب. دائما يكون في حشد وجهود مناصرة من قبل منظمات محلية دولية لدعم هذا القطاع الصحي لاستقطاب المانحين وتسليط الضوء على المعاناة في شمال غرب سوريا. تشكيل لجان أجسام كيانات كمديرية الصحة كنقابات لدعم القطاع الصحي. إنشاء نظام تم إنشاء نظام إنذار مبكر يعمل على مدار الساعة للتحذير من أي خطر هجوم. توفير عيادات نفسية نقالة أو نقالة اللي هي أو مراكز صنع التركيب، بحيث أي هجوم ممكن يتم نقل هذا المركز إلى أماكن أخرى بعد الاستهداف المستمر، اللي هي ضمن توفير مشافي ميدانية أو مراكز ميدانية للسلطة للفك والتركيب. وضع آليات صارمة للمساءلة لانتهاك أي إنساني خارق. التقييم المستمر دائما لضبط الجودة وتأسيس المنشآت، حرص على تنشيط في أماكن، هذه المنشآت تكون في أماكن آمنة بحيث أنه ما يتم تعريض الأشخاص اللي يتم تخديمهم في هذه الأماكن الغير آمنة. شكرا. يعطيكم العافية.
Thank you so much, Ala, and thank you, Mace, for helping us English speakers to hear what Ala had to say. And I'm hearing that term, investing in the manpower, investing in those practitioners, and it sounds like training, but also we heard about from our other colleagues about investing in them, in their health, in their well-being, in what they need to survive in this situation. So I really second that need to invest in that. I would now like to call Dr. Amar, who I believe is with Salah in the Hope Revival office. This is our beloved colleagues at Hope Revival organization in Gaziantep in Turkey. Dr. Amar is a leader as a psychiatrist in the community, the Syrian community. He has been a leader in trying to help coordinate the system response in Northwest Syria in many of the ways that Ala was describing. So Dr. Amar, can you hear us?
أستطيع الكلام؟
There you are, we can hear you, beautiful.
الصوت مسموع؟
Yes, please, go ahead.
Yeah. Hello everybody, Assalamu alaikum. My name is Ammar Bitar, I'm a psychiatrist, and I have been working in the field of mental health for the past 20 years at least. I did my qualification basically from Pakistan. Then I continued post-graduation in Syria. I will talk about the mental health services before 2011 and after. And I will give a brief about the MHPSS working group for Northwest Syria. Actually, the services of MHPSS before the war was focused in the major cities. It was connected to the universities and to the two main hospitals in Damascus and Aleppo. The services were medical based and
Dr. Amar, we've lost your sound, but we still have your picture. Why don't I give you a moment to see if we can resolve that? And perhaps we can see if there are any questions or comments related to the speakers that we've heard so far. If anyone wants to put up your hand, feel free. I have a question for our colleagues from Gaza. You spoke about the issue of fragmentation of services and the need to, I guess, support staff by providing them with consistency. Just wondering whether, if you have any suggestions for the international community about how to reduce the fragmentation, because people might often rush in from the outside, but it might be very difficult to understand how to connect into the existing services and into supporting those existing staff. Do you have any suggestions for international actors for how to prevent that fragmentation?
So there is one umbrella, big umbrella for the mental health services in Gaza, which is Ministry of Health. The General Director for Mental Health in Gaza. Supposedly they are the one who are responsible for organizing, allocating resources, and so on. However, this typical director at this moment, at this situation, is not taking good care of, because the Ministry of Health, health system overall in Gaza, it is already collapsing. The intellectual people who were able to manage the people who are able to manage this are not here at this moment. They have all evacuated to safer places, and people who are not very experienced, not well qualified, are the ones who are in charge at this moment. I don't know what other organizations can do at this moment. I think they have to be proactive about it, to ask what we can do, to ask to do some of the service promotion. There is another thing that is going at this moment, which is mental health cluster. This is a regular meeting already. It's already going on, but I don't know. I'm not part of it, so I don't know exactly what is not going well with them. They are supposed to share together their experiences, promote the services. But I believe this is those who are in higher management get to know what is going on in the health cluster, but the other staff are not knowing what is going on. That is why I was able to talk with those staff, the working staff, not the managerial ones. So that was, there must be some fragmentation in their aspect, in their eyes.
Thank you so much, Nariman. And Salah, it seems like you're back online. We can't hear you. this is our experience as we connect with each other. We've been running a supervision program for about 3 years, and a lot of it is waiting for the sound to come through. Can't hear you. Okay, we'll see if we can solve that issue. And I just wanted to ask Allah, I know that you have probably been connected with the cluster, the mental health cluster in Northwest Syria, and that experience of trying to coordinate.
Can you hear me now?
Yes, we can hear you. Okay, perfect. Take it away, Dr. Ammar.
Okay. Share. Okay. So as I was mentioning before, so it is okay now. The sound is okay. Okay. Mental health services in Syria, as I mentioned, was focused in the big cities. It was governmental and private sector. It was located in the cities where there is universities. The services were provided by the hospitals of Ministry of Higher Education as well as Ministry of Health. There is 2 big hospitals in the country, and the country was referring cases to these 2 big hospitals according to certain quota. There was no, what we can say, modern governance of the mental health services. Non-medical services did not exist, and even if it was there, it was on very small scale and connected to individual interest and capacities. There was an entire governorate where there was no mental health services. The services started improving with the war in Iraq and the influx of the Iraqi refugees to Syria. By that time, the UN agencies, the UNHCR, WHO, and UNDP started building capacities and offering the concept of PSS, psychosocial support, and the other areas of protection, GBV and child protection. Mental health services was initiative was mainly focusing on capacity building and on utilizing the local capacities. By that time, training on case management and the psychosocial work started. With the consequences of let's say the Syrian revolution, the fact that the military operation started in Syria by 2011, after 5 or 6 months of the revolution. The mental health services in northwest Syria did not exist, meaning to say the 2 major big cities, Aleppo and Idlib, they were under the control of the government, and most of the physicians, psychiatrists left the cities. The services of Ibn Khaldun Mental Hospital was stopped after it was involved in the military operations. Consequently, the first news of MHPSS working group for Northwest Syria was in August 2015, and needs assessment was done by Dr. Boris Botsdan at that time. Very few services were available, 1 psychiatrist and few MHGAB based services. MHGAB is the manual of training of doctors to non-specialized doctor to offer mental health services. The training started by the end of 2018. 5 clinics were established in Northwest Syria. Some other primary healthcare centers have few psychologists or psychological counselors who offered some services. Ultimately, the capacity building plans and the work started by early 2016. Currently, what we have achieved, we have around about 130 MHGAP practicing doctors following regular supervision by WHO. We have around about 450 to 500 psychosocial workers who were trained on the manual, which was mentioned by my colleague Ala Al-Ali. And further capacity building was done for specialized, non-specialized interventions, medical and non-medical as well. Luckily, we caught the attention of GIZ initiative for training supervisors. Currently, there is between Northwest Syria and Southeast Turkey, there is around about 39 trained supervisors who offer clinical supervision via different means, either directly or online. This is the MHGAP services is primary healthcare focused. We have 3 centers for or 3 acute psychiatric care units. These acute psychiatric care units are can accommodate around about 60 to 70 patients, inpatient. It offer also outpatient services. The number of the psychiatrists by the since 6 months, we succeeded to graduate 3 psychiatrists from the Syrian capacity building program, SPOMS. This added to the existing services. And yesterday I was part of a lecture delivered by Dr. Radwan Khayyat, who is a psychiatrist based in UK, in the capacity building and residency program, which was started by the collaboration of ECO with awesome organization. And it encompassed 8 residents, and they had been examined on the, they have a course of neurology and internal medicine, and they will start working in the 3 acute psychiatric care units. The MHPSS working group currently encompasses of 25 to 30 organizations. These organizations are INGO and local NGOs. We have regular meetings, we have annual plan, we have advocacy activities. We are coordinating with a lot of the other areas of work like WASH, protection, and livelihoods, etc. We have a capacity building needs assessment, and we plan trainings and capacity building based on this needs assessment. And actually, we also succeeded to, as a group, to start doing research in the different areas of MHPSS. Care for Carers is one of these research initiatives, which is focusing on evaluating services without and with supervision. And then, you know, all this work need a lot of efforts, capabilities, advocacy, financing, and a lot of coordination. And ultimately, as we have learned from the 10 years, now 12, 13 years of the Syrian revolution and the military operations, you invest a lot, you work persistently, tirelessly, and then a military operation come and wipe everything away. And this is unfortunate. And we have been seeing that throughout the past 6-7 years. Of course, services are continued based on the availability and safety of the teams that offer MHPSS services. But as we can see now in Gaza, a work of decades go in just time of days or weeks. Thank you.
Thank you so much, Dr. Amar. And yeah, I can, I guess, have witnessed over many years the tireless work that you and others in the community have been doing to build and then rebuild, only to watch things get destroyed again, but then to rebuild again. So I guess that's just a testament to your tenacity and resistance. And so thank you so much for sharing as well what has been achieved in these years as well in Northwest Syria to keep building opportunities for people to get involved in the mental health system. Okay, thank you everyone. And I don't want to take too much more time because people probably want a bit of a break. We've heard a lot of really big supervision is a way that we can provide solidarity and support and to help people keep going in that work. So I'm very happy to introduce my two colleagues, Gülşah Kurt and Fatima Al-Meamari, who will be presenting some results from the Caring for Carers study, talking about the impact of supervision on practitioners and how people used supervision as a space following the earthquakes in 2023. So I'll hand over to you.
Hello, everyone. Can you hear me? Thank you so much for joining us this morning, evening, afternoon in your time zone. My name is Gülşah. I'm a postdoctoral research fellow at UNSW. And today with my beloved colleague, Fatma, and I will be presenting the very first results of our supervision program. And before I start, I would like to express my solidarity with the survivors of the earthquakes after Turkey-Syria earthquakes in 2023 and express my grief to those losing their life on an untimely basis. And before I move on, I would like to give floor to my colleague Fatma to introduce herself briefly. Then we're gonna get moving on with our presentation.
Hello, everyone. Thank you, Gülşah. My name is Fatma Al-Meamari, and I'm a clinical psychology student doing my master's. And I do support and translation work in the Caring for Carers project, and I'll be glad to present the results with Gülşah today.
Thank you. And as I said, today we will be presenting the very first results of our supervision program and the role that the supervision played immediate after of the earthquakes for our practitioners in the program. And yeah. As you might know, last year in February, 2 major earthquakes hit the southeast part of Turkey, affecting the whole region and Syria. More than 15 million people in Turkey and 8 million people in Syria were profoundly affected. Thousands lost their lives and hundreds of thousands were injured. Millions of people lost their homes, their livelihoods, and their loved ones. And when the earthquakes happened, we were 3 months into our supervision program in Turkey, Syria side of the Caring for Carers project. And we had an opportunity to observe the role of supervision for mental health practitioners in our program, providing support to those affected by the earthquakes in their region. Before moving on with what we have found, I would like to briefly introduce you to the C4C project, Caring for Carers project. Yeah. C4C project is a mixed method longitudinal research project based on participatory research practices, and it is provided to Syrian mental health workers in Northwest Syria and Turkey, and Bangladeshi mental health workers in Cox's Bazar, providing support to displaced communities in their respective settings. The supervision program is provided by one local and one international supervisor to the group of 6 to 8 practitioners, and over the course of 16 months. And we've been collecting several forms of data in the past 2 years, monthly survey data from the practitioners, monthly interviews with the displaced communities who receive psychosocial support from the practitioners in our program, and the identified version of the recordings of supervision sessions. We had 6 months of, can you see my screen? I think it's not moving on the Zoom. Yeah. We had 6 months active control periods during which we collected monthly data from our practitioners and provided several educational materials about mental health and supervision. We started the supervision program in October 2022, and the earthquake happened 3 months after the beginning of the supervision program. Following the earthquakes, we suspended all the project activities, and we focused our efforts on checking the safety of the practitioners and project staff in the affected area. And we organized webinars, some workshops, and provided materials that could be useful in the immediate after of the emergency. This slide basically shows the data collection before and after the earthquake that were included in the present study. We had 55 Syrian mental health workers in our program during the active control period, of whom 47 continued to the supervision program. Majority of the mental health workers live in Syria and internally displaced. And at the baseline, 90% of our practitioners in our program scored above the clinically significant distress level, showing that there's heightened level of psychological distress even at the beginning of the program. And we conducted both quantitative and qualitative investigation to examine the role of supervision for mental health workers in our program in the aftermath of the earthquakes. And I will be presenting the findings of the quantitative results, and Fatma will talk to you about the results of our qualitative investigation. We found the initial evidence for the positive impact of the supervision program for psychological distress and the compassion satisfaction of mental health workers in our program by showing that compared to the active control period, the level of psychological distress and compassion satisfaction improved in the pre-earthquake supervision program, which is the first 3 months of our supervision program. And we compared the post-earthquake to pre-earthquake and active control period to see if the maintenance, if the gainings of the supervision were maintained after the earthquakes. And for psychological distress, post-earthquake period was not different from the pre-earthquake and active control period, with practitioners' psychological distress scores lying somewhere between their baseline psychological distress level and pre-earthquake supervision period. And for compassion satisfaction, gainings were not maintained because in the post-earthquake period, their scores were significantly different from their pre-earthquake period. However, it wasn't significantly different from the active control period, which shows that even though they didn't maintain their initial gainings from the supervision period, but they didn't worse off compared to their baseline scores. Yeah. You can see the comparisons here. And I think we see a different interface in our recording, but okay. Yeah. Okay. Now, Fatma will talk to you about our qualitative examination of the supervision sessions and the interviews with the supervisors to unpack the supportive role of supervision during this time. Fatma, can you see the qualitative part, or is it still the quantitative one?
I'm switching now between the slide. Yeah, now it should be on the qualitative one.
Okay.
So I will present the results of the qualitative data analysis. And for the qualitative data, we looked at semi-structured interviews with supervisors in the program, 5 local and 5 international. And we also looked at video recordings and transcripts of supervision sessions, 9 sessions in total, immediately after or during the earthquake period. And the purpose was to look at the role and functions of supervision within this time specifically. How did it change, and what were the most helpful aspects? And we looked at these data and these transcripts through doing thematic analysis with elements from grounded theory. And we coded the interviews for important themes and processes, and there were 2 independent coders, and we matched our codes together to come up with the final themes. And we used this umbrella metaphor to describe the themes and this role of supervision during this critical time. And as you can see here, supervision was mostly seen as a safe space with 2 main key functions, being emotional support and practical support. The key features of supervision that we saw, and the key roles of supervisions that we saw function, is the fact that it was very supportive in supporting practitioners following and during the earthquake. And the content of the sessions changed from being mostly focused on case discussions before this period to focusing more on how practitioners are coping with psychological distress themselves, how they are able to support their clients within this crisis period. And supervision was a safe space for them to be able to share their experiences. And particular things and elements within supervision that made it supportive was the genuine presence of the supervisors that were there to support and respond to them and connect them with their group members, to share resources, to share knowledge, and just to have a supportive space. And also having the space to share their difficulties and experiences. And another really important thing that came up was that it created a sense of normality in such an abnormal situation. And it kind of made it a single constant thing. In the words of one of the supervisors, it was really striking and showed us how it kind of had the sense of continuity in this time. And they said having the supervision continue gave a sense of normality, that there was something that was hoped for that could go back to normal. Everything changed, and this was a constant thing that stayed the same. And of course, another really important element of supervision during this time was empathetic listening and empathetic responding to what the practitioners share in terms of their experiences and difficulties. And in terms of the roles, the functions of supervision, again, like 2 of the main functions that came up was that it was a space for emotional support, where practitioners could share their experiences and their emotions related to the earthquake, such as feelings of struggle and the experiences of re-traumatization, and any sense of fear or any sense of loss and grief. And in response to that, we could see in the transcripts that the supervisors normalized and validated these responses and emotions, and helped the group to share with each other ways that they cope. And the coping strategies were shared by the supervisors and the practitioners themselves with each other, And one of the most important coping mechanisms that were supportive were religious and spiritual coping, and finding also meaning in community support and in the help in the work of helping others. And also finding support between peers and colleagues, and also through family members, and finally also through self-care activities, such as being in safe spaces or comfortable spaces, and doing sports and other hobbies that are possible to practice. The second function is that it provided a space for practical support, where it was possible to discuss the needs of clients, specifically vulnerable groups like women, children, and the elderly, and how to support them in this difficult time. They also discussed specifically the importance of creating a sense of safety and normality for children, because also they are affected differently than perhaps their parents are, and how to support basically the parents and the children during this time, and support the parents kind of have the capacity and also supporting their children. And they also discussed the psychological reactions following the crisis situation, and discuss important strategies such as psychological first aid during especially the early stages of the crisis, and the importance of connecting the beneficiaries and the community members to their essential needs. They also highlighted the fact that not all the people who are exposed to crisis develop traumatic responses or mental health problems. So it's important to focus on community support building. And in terms of children specifically, they discussed the teaching recovery techniques method, which is specifically used in addressing PTSD-related symptoms, and is based on trauma-focused CBT techniques. In this sense, they shared different knowledge, different practical tips and skills in order to support each other and continue supporting their community members. And finally, to conclude, throughout both our quantitative and qualitative results, we see the stress buffering role of supervision, and we also see how supervision acts as an umbrella, helping the practitioners and workers not to get completely exposed to the stressors, although of course it cannot provide a full protection. And it's important to consider specifically how this affects mental health workers who are local, because they are usually the first to arrive and the last to leave these crisis situations. And it also shows us how supervision is crucial to ensure effective and quality delivery of psychosocial support. And it shows how it acts as a protective factor, highlighting the importance of support, solidarity, and community in general, and specifically in times of suffering. Thank you, everyone, for listening.
Thank you so much to both of you. And I think I would also just like to acknowledge that both of these researchers, Gülşah and Fatima, were also living in Turkey at this time, and both responded to this situation themselves, trying to find solidarity, to support the people who are affected, travel to the areas to provide support, or to make sure that everyone on our team was safe. So thank you so much for what you've done to kind of look at what happened in that time in the supervision. I would very much now like, oh, it looks like we've got a question. Angela, did you want to ask a question before we move on? I will press this button that says allow you to talk. Would you like to ask a question?
Thanks, Ruth. Yes, that was really interesting. I wondered, particularly given what Ruth said earlier about the challenges with technology for the international supervisors, whether you noticed there was any differences in the responses between the domestic and the international supervisors.
Did you want to answer that? Did you want to answer that? She was talking about the different problems with internet and people getting in contact. Was there a difference between international and local supervisors?
Thank you very much for the question. Yes, Fatma can also reflect on this much, but we saw that internet connection and using Zoom or any other mediums was a great challenge for local supervisor, considering that they are based in settings where access to internet and the stable infrastructure to join the sessions are very much limited. So their attendance, even if they were so willing to join the session, sometimes impaired by these contextual barriers. But on the other hand, I think encountering with such barriers on the part of international supervisors must be a different experience to see that someone in the different part of the world, even struggling with access to internet and join the session. So, yeah.
Thank you.
Ruth, can I comment on this, please, if you don't mind?
Dr. Marwan, yes, please.
Yes, hello, everyone. My name is Marwan Diab. Just to comment on Angela's question, I think for people who are living in war zones and people who are living in very dangerous situations, sometimes you would think that having a counselor from within, a local counselor, it will help. However, that person normally they are exposed to the same circumstances. They are exposed to the same violence. So the ultimate solution is to have an international expert or supervisor to provide such intervention. However, due to the electricity and some online cutoff of different things, this is also impossible to have in certain. How maybe they could do a phone call supervision rather than just an online stuff. So we have found that having phone calls to the people, if there was a mobile services, are very helpful. Thank you.
Thanks. That's a really good point.
I think I've even heard of people doing this via text message, via WhatsApp. Yeah. Okay, so I think I'll move on to the next panel that we're going to have, where we're going to hear from some supervisors, one of whom is Dr. Marwan, who is joining us from Canada. We also have Dr. Nahla Haj Hassan, who is a beautiful Syrian psychiatrist who has been one of the supervisors in our program, has been operating remotely, and also Mr. Ahmed Khaldo, who himself lives in Northwest Syria and so has battled with these internet connection problems and has stayed with us for this whole program. So first of all, I will hand over to Dr. Marwan, and then we will move through the others. So thank you.
Yeah. Can you see my screen?
Yes.
Okay. Thank you very much for having me in this session. My name is Marwan Diab, and I am Palestinian from Gaza Strip. I'm just going to talk about the clinical support of supervision in the context of the Gaza Strip. And I'm a researcher at Stellenbosch University, South Africa, and I'm also a mental health psychosocial support expert in Palestine. Just going to talk first about the context. As you know, the Gaza Strip has been under siege for the last 17 years, and it has endured many different Israeli offenses in 2008, 12, 14, 22, and more recently, 2023. And I don't want to go into this because you have seen all the atrocities that are happening on TV and internet and social media. This was in October 15 when I was in Gaza myself, and I'm in this car here. This was my Guido's and my favorite car when he was there in September 2023. And this car, as you can see in the red, that's the destruction that was happening to us during the October, the same evening of that October 15. And this is in Rafah, where we were evacuating from the north of Gaza to the south of Gaza. And as you know, that the occupation forces target all infrastructure, including educational and health facilities. Electricity and mobile networks are normally cut off. Sometimes they are on, so it's difficult to conduct online sessions. We have to start always from point zero. So if you have built a system of support, always you have to start again. In this point, I'm responding in a way to one of the colleagues who was mentioning that the authorities don't have the right planning for systems. But I tell you, even if we have the planning, if we have the policies, if we have all the facilities, it will be destroyed by the Israeli occupation. So the work of the counselor normally is very difficult and emotionally draining. You have negative feelings, emotion, and anxiety as a result of the work. You and caregivers or carers will experience, some might experience, I don't want to say will experience eventually burnout if they are not taking care of themselves and others. So what we do, burnout is a recognized syndrome. People who are vulnerable, who give too much, they are always giving too much from their own at the expense of their own needs. And I'm just gonna trying to move this bar away. Okay, and if they don't do if they do this for a long time, then they will experience a whole bunch of problems, including exhaustion, lack of motivation, loss of job satisfaction, resentment of the work, and different aspects. I don't want to go in details of that. Okay, one can prevent burnout by means of supervision. We need the support of supervisor to reflect on the work, and working under supervision means the counselor uses the service of another experienced supervisor. I know, just wanna do. Okay, supervision is not a managerial role. I think this has been a confusion in this setting, that supervision is a managerial role, and the supervisor is not the boss. He cannot be the boss, and he's the consultant. And who needs supervision? All counselors need supervisions, or psychotherapists, or service providers in general. They all need supervision. I think my screen is going by itself in there, so let me. Can you still see my screen? Can you see my screen, guys? Okay, yeah, okay, sorry. It was going on automatic. So in here, what is a supervisor relationship? Supervision is an intervention that provides senior member to a junior member. So it's a safe base or safe place for people to talk about their feelings and emotions as a result of dealing with the clients and people who have had some difficulties, including stress and trauma. And clinical supervision should be mandatory for all people who are in this profession. Supervision should be conducted in adherence to ethical and legal standards. It's bi-directional feedback from the supervisor to the supervisee, and evaluation of the supervisee competence areas. And it's different from consultation or personal psychotherapy or mentoring, and it occurs within a respectful and collaborative supervisory relationship. Okay, so things to consider when working as a counselor: you have to take some time to think about yourself and your needs, recognize the stressful nature of your work, learn about the kinds of stress that you and your colleagues are dealing with, and you have to set realistic goals to yourself and not to stretch yourself too much, and also help to develop a good system of formal and informal support for yourself and for others. This is okay. So what support do mental health workers need in this setting? As you know, foreign humanitarian service providers have been killed in the Gaza Strip recently. 7 aid workers from World Central Kitchen were killed as part of their intervention in the Gaza Strip. And so what do mental health worker providers need? They need protected space areas. They need psychological care and support to be provided to them first. So they are part of the context themselves, and they are exposed to the same magnitude of violence. Therefore, they need somebody to look after them before they start looking after people. They need an appropriate space to provide such intervention, and flexibility in terms of vacations and taking breaks. This is an administrative role, so they cannot be expected to have regular schedules in such circumstances. And one of the most important thing is recreational activities on a regular basis. And we found that this is a very important aspect during the times of stress for professionals, and they are very satisfied with such services. We need to encourage them to engage in enjoyable life activities, reducing workload, reducing the number of hours, and give them a break. If it's possible to give them a break outside, it's nice. If not, then give them a break within the context, even though it does not help much. And of course, providing them continuous training and refreshment of their information, just to keep up to date with the state of art. What we have learned from providing supervision in the context of Gaza is providing appropriate physical and health service to the professionals. We need to provide such services immediately and provide basic needs of for the beneficiaries themselves, and paying attention to the emotional and psychological aspects through effective listening, empathy, understanding, and identifying priorities of the beneficiaries. And we also learned that paying attention to the social aspect, which through connecting people with their social networks is very important, as well as preserving their dignity, safety, and human rights. And the most important thing is to have their legitimate rights. If they have their human rights respected, then there is no need for us to intervene. But unfortunately, there is lots of human rights violations that are happening. Therefore, our work is needed to help the clients and help those who help the clients as well. How can we set up sustainable support systems, providing supportive supervision to all workers at the technical and the administrative levels? I'm just going to share with you just quickly here some of the perspective of the supervisees and the supervisors that we have worked with. We had 18 participants from supervisees and 15 from the supervisors, and the interviews with them came up with that the benefits of the supervision was it has impacted positively on their professional development and professional lives. They gained skills in assessment and management of common mental health problems, and they had experience in exchanges of experience between themselves, and an opportunity to discuss difficult cases. And at the personal level, it helped them in maintaining good mental health and reducing their anxiety and having good communication skills. And we found challenges in the supervision. So normally, the administration were not aware about the importance of supervision. That's one thing. And it was not an obligatory thing. So it was just whoever who wants to have this supervision, they can have it. It was not something that was part of their job. And there was lots of poor coordination, which impacted the attendance of the supervisees. One of the people who participated mentioned that they think that conducting supervision is a waste of time. They don't even thank us for. So this was one of the supervisees talking about the ministry that did not approve their supervision sessions. So she was not satisfied with the way the administration is looking at the supervision. Do you think it's something that's luxury and it's not a very important mandatory thing? And sometimes the managers of the organizations or the settings would like to know more information about the session, how did it go, and that also posed a challenge for them because the supervisors cannot reveal any information about their supervisees. Poor logistical arrangements was another thing. Also, there was no safe place. As mentioned, we used to conduct this session in our office, which was not comfortable and not private. So this was also another challenge. More challenges are stress and work related challenges they have faced. They do the supervision as well as the regular work, which is really too much stress as well, and that defeats the purpose of having the supervision. Field work that affected their ability. Once they finish their field work, they come to the supervision session. So as said, when I come back from my field work, I used to be exhausted and tired. How will I help others when I can't help myself? I have to empty my own cup first. And there is no recognition from the administration for this, and which impacted the motivation. And at the beginning of forming, supervisors felt anxiety. Normally, the supervisors will feel anxiety because this will add extra burden to their work. More challenges was the heterogeneous aspect of the group. They were not homogeneous. The supervisors didn't have enough knowledge of the significance, so the supervisees did not think the sessions were important enough. Supervisees were thinking that this is an evaluation of their performance. Therefore, they were hesitant to talk about things freely. The work stress also severe enough. So they were so stressed out that they didn't even have time to be supervised, which is also adding a burden to them and affected their commitment. And some principals were not cooperative in the school system. Some of them were not cooperative and did not encourage the participation of the counselors or teachers in such supervision sessions. Recommendations is to conduct regular meetings and awareness sessions, to have this in part of the job description and action plans. Okay, yes, am I done? Go ahead, please. Ruth.
I was just mentioning that time is running out, so I was giving you a little indication. So please,
no, I'm almost done.
if
Almost
you want
done.
to finish, yeah.
I'm almost done. Thank you, Ruth. So to ask coordination between different organizations and create safe places, and to have the supervision spaced out in a monthly basis. It was recommended by the participant rather than having it every week because it was exhaustive for them. To use several diverse techniques rather than just the same routine techniques. Needs assessment is very important in the beginning. Schedule ahead of time the supervision sessions, the homogeneous groups, and to have a module to follow, not just any ad hoc basis supervisions. This was not the case. There was no module of supervision supportive to service. So we need that established. One last thing is to have theories for supervision, follow-up sessions, expertise exchange, and additional training in different self-care and burnout. And way forward to have a national strategy for supervision, to have a module in universities, or to form a union for supervisors and exchange experience between Gazans or supervisors from Gaza and international expertise. One thing I just want to emphasize that this was told to me by one of the counselors in Gaza Strip, that we are sharing in the human rights violations because we are preparing victims for a new wave of violence. Because once you deal with the clients and help them recover at the end of the stage, like they are almost recovered, you'll have another wave of human rights violation by the occupation. Therefore, we start over again. So, and this is really something that I think it's what's happening. So thank you very much for having me. And I'm sorry if I was longer than I should have.
Thank you so much, Dr. Marwan. And if nothing else comes out of this webinar, I'm just so happy to see this work, because I think most of those challenges and recommendations that you have made are probably the exact same things that we have found. So it's really amazing to see. So I hope we can keep talking after this about your work.
Sure.
Yeah. Perhaps I can now invite Dr. Nahla to share your experience of providing supervision.
Thank you so much, Ruth. I'm going to use Arabic actually, because this is very much, touching and emotional for me. So thank you very much. تحياتي جميعا. أنا نهلة الحاج حسن، طبيبة نفسية من سوريا، أقيم حاليا في غازي عنتاب في تركيا، وأحمل جنسية هذا البلد اللطيف اللي استقبلني على مدى سنين، والهوى فلسطيني صراحة من لما كنت كتير طفلة صغيرة. هلا جولشا وفاطمة حكوا أكاديميا عن البحث عن C4C. دكتور مروان حكى بشكل علمي عن التحدي والتعاريف وهي الأمور اللي بتتعلق بالإشراف. أنا خلوني شوي أحكي بشكل يمكن أدبي أو شعري عن تجربتي الخاصة أنا الشخصية جدا مع C4C كمشرفة بالفترة اللي فاتت من تقريبا سنة و7 شهور. بلشنا مثل ما حكت جولشا بأكتوبر 2022. كان معنا مجموعة من المشرف عليهم الزملاء بشمال غرب سوريا، مقيمين هنيك وبيشتغلوا هنيك بخدمات صحة نفسية. فبفترة الزلزال أنا كنت بعنتاب، وقدرت يعني الحمد لله أن أطلع على اسطنبول لمكان آمن. بكل الأحوال حتى بالفترة اللي ما كنا لسه أنه طلعنا فيها كنا عم نحاول دائما نتواصل ونطمن على بعض. كان معنا زميل مشرف مقيم بأوروبا هو سوري، فكان كتير عامل مهم باستمرار الدعم واستمرار الجلسات بهذيك الفترة لفترة شهرين كاملين بعد الزلزال. نحن ما حكينا أبدا عن إشراف بيتعلق بالحالات أو بيتعلق بالمواضيع اللي بتتعلق بالشغل أبدا. كان المهم بالنسبة لنا أنه نحكي أكثر مع الزملاء أنه هن كيف عم يتكيفوا مع الوضع، شو عم يعملوا، كيف فينا نساعدهم، أو كيف فينا خلال الجلسات نفكر بأمور تخليهم يكونوا بخير أكثر. ما رح أقول بخير تماما، ولكن بخير أكثر. هذا الشيء كان يعني حسب ما كنا عم يوصلنا كان عم يعمل مفعول كتير كويس وأثر طيب كتير عم يترك. زملاء كانوا عم يشتغلوا جزء منهم برفع الردم، بدفن الضحايا، جزء منهم عمليا دفن أشخاص أقارب وأصدقاء له. فكانت الجلسات عم تعمل شيء هيك روتيني، إنه في مساحة آمنة لنقدر إنه نحكي ونتشارك هاي التجربة ونشوف شو ممكن نعمل. والشيء اللي أنا بصراحة كتير ممتنة له كنت ولا أزال إنه رغم كل هي الظروف الصعبة اللي كانوا عم بيعيشوها كانوا يقدروا يلاقوا وقت ليحضروا الجلسة. ما حدا تغيب وما حدا اعتذر خلال فترة هدول الشهرين. فبالنسبة لي هذا كان شيء كتير كتير مميز وكتير نوعي صراحة. وبعد ما خلصت الجلسات وخلص المشروع رجعنا سمعنا منهم إنه نحن لسه بنتذكر بوقت الزلزال كيف الجلسات كانت بس تدعمنا، ما كان شيء له علاقة أبدا بالشغل أو بالادمنستريشن أو بأي شيء تاني. كنا بس قادرين نلاقي مساحة آمنة لحتى نحكي أو نسمع ونسكت، إنه المساحة آمنة بس لإلنا ومشان. فهذا الشيء كان كتير مميز صراحة. بالفترة اللي بلشت فيها الحرب على غزة الجميلة، كمان بشمال غرب سوريا صراحة كان في تصعيد لسبب أو لآخر. فبأول 10 أيام من الحرب على غزة كان في 60 أو 70 شخص بشمال غرب سوريا عم يرجعوا ينزحوا للمرة الأولى أو الثانية أو العاشرة أو ال20، تقريبا نفس التجربة يعني. فكمان حاولنا أنه نعمل هاي الجلسات مساحة أوسع فيها نعطي، لأنه كمان الزملاء بنفس الوقت يحكوا عن الشيء اللي عم يشوفوا وعن كيف عم بيحاولوا يتكيفوا مع الوضع. بهي المرحلة كان معي مشرفة صراحة كتير هيك أصيلة وحقيقية ومميزة من أستراليا، هي روبن. وروبن وجودها كان هيك عطى لمسة كتير حلوة وحقيقية وهيك إنسانية للشيء اللي عم بيصير، لأنه هي حدا من برا بس عم بيحاول جاهدا إنه يدعمنا ويشاركنا هذا الشيء اللي عم بنعيشه. فكمان كانت الجلسات كتير زملاء عبروا عن امتنانهم وحكوا يعني كنا قادرين نلاقي مساحة ونسمع شيء هيك صريح وحقيقي بالشيء اللي عم بيمروا فيه. وطبعا بهديك الفترة كتير نذكر موضوع فلسطين، لأنه بالنسبة لهم وقلنا طبعا أنا بمكان آمن، ولكن بالنسبة لهم الشيء اللي عم بيعيشوه، ودائما فلسطين هي شيء كتير مميز بالنسبة لنا كعرب وكسوريين. أنا حسب الشيء اللي بعرفه عن كتير ناس بقابلهم وبعرفهم، فهن كنا انه يحكوا انه نحن كنا نحب فلسطين وندعي لها ونتمنى لها الخير ونشوف شو اللي عم بيصير فيها ونتعاطف معهم كثير. بس هلا صار الوضع اعمق، لانه صرنا نحن الاثنين مثل بعض، صار فينا عن جد عن جد لما نقول لهم إنه حاسين فيكم وشايفين شو عم يصير معكم، إنه نحن عن جد عم نحكي هذا الشيء بشكل حقيقي. ففعلا يعني كانت الجلسات هيك عم تعطي أثر مثل تماما ما ذكرت فاطمة بالنتائج الكوانتيتيف والكواليتيف. أنا مثل ما قلت لكم ما رح أحكي بهي الصيغة، ولكن رح أحكي أكثر بالصيغة هيك العامة لهي التجربة. واللي بدي أقوله بصراحة إنه لما بتكون العلاقة بالإشراف بسي فور سي كنا عم نحاول دائما نعمل العلاقة مو بس على صعيد مهني، يعني إنسانية على كل الأصعدة. أنا ما بس بدي إنه مهنتك تكون منيحة وشغلك مع المستفيدين أو متلقي الخدمة أو الكلاينتس يكون منيح وتمام والخدمة توصل بشكل منيح، لا، أنا بدي أنت كمان تكون منيح. العافية النفسية لك كمقدم خدمة صحة نفسية تكون منيحة. أنا بدي بكل جلسة مثل ما مهاراتك رح تتحسن مع المستفيدين، كمان عافيتك النفسية وصحتك تكون بدرجة أحسن، تكون أنت بخير أكثر. وهذا الشيء وصل بشكل كتير أصيل وجينوين للزملاء المشرف عليهم، ونتائجه كانت واضحة بالنسبة لنا كمان هيك بشكل يعني مقابل وصل لنا كمان. فاللي بدي أقوله إنه لما بتكون العلاقة بالإشراف صراحة هي علاقة إنسانية على كل الأصعدة المهنية والإنسانية، ومين عم يقدم الخدمة ولمين عم تتقدم الخدمة وكيف عم تتقدم الخدمة وجلسات الإشراف كيف عم تصير وكيف عم نتعلم بعض ومن كل هي النواحي. فبيصير الإشراف بحد ذاته هو ميزة، وبصير قادر إنه يتميز أكثر ويعمل فرق ويترك أثر طيب ومتعدي ودائم صراحة. فهذا تقريبا كل شيء بدي أحكيه عن تجربتي بالإشراف وخلال أزمتين اللي هن زلزال سوريا وتركيا بال 2023 وكمان بنهاية 2023 العدوان والحرب على غزة والشيء اللي رافقه ما يشابهه من اللي صار على شمال غرب سوريا. وبشكركم كثير لأنه سمعتوني، وشكرا كثير روث.
Thank you so much, Dr. Nahla, for speaking from the heart. And I think we can all perhaps experience a little of what your supervisees experienced in having you, and also Robin there to support them. So thank you so much. I would now like to invite Ahmad Khaldo to give us your reflections about your experience in supervision as well. Can you hear us there, Ahmad?
السلام عليكم.
عليكم
صباح
السلام.
الخير، مساء الخير. مسموع صوتي بشكل جيد؟ تمام. الله يعطيكم العافية جميعا. أنا أحمد خالدو، خريج إرشاد نفسي جامعة تشرين. طبعا بشتغل حاليا مع منظمة إحياء الأمل، اللي بفتخر فيها كثير أكيد. طبعا بشتغل فيها كمشرف صحة نفسية ودعم نفسي اجتماعي، أيضا بالإضافة لمهامي كأخصائي نفسي. وطبعا أنا مدرب معتمد بالمنظمة ومنظمة الصحة العالمية بأكثر من موضوع. طبعا الشيء اللي بدي أحكي فيه حاليا هو يعني بدي أتركز بشكل كبير بعملي كمشرف، سواء بمنظمة إحياء الأمل أو بمشروع سي فور سي اللي نحن بنفتخر أيضا بالعمل فيه، لأنه فعلا قدم نقلة نوعية كثير كبيرة بمجال العمل بشمال سوريا. طبعا أنا ما بدي أحكي شيء خلينا نسميه نظري. التحالف الإشرافي يعني هو بتركز أكثر شيء على العلاقة والديناميكية، يعني بمعنى التفاعل بين المشرف أو المشرفين والمشرف عليهم. أنا شخصيا بشوف كأحمد خالد إنه أهم شيء بهذا التحالف أو العلاقة الإشرافية إنه المشرف عليه يحس إنه في عنده فسحة، عنده مكان لمناقشة أي شيء بيخطر على باله، مهما كان صعب، مهما كان خطير، بدون حرج، بكل سهولة ويسر. أما بالنسبة للمشرف فهو من باب الأمانة الأخلاقية والمهنية يفضل أنه يفعل كل شيء من شأنه أن يوفر للفريق المشرف عليه الاهتمام حتى يكون جاهز حتى يقدم خدماته بكل الطرق الاحترافية والمهنية مع المستفيدين اللي بيتعامل معهم بطبيعة الأحوال. أنا بشوف أنه أهم ثغرة أو فجوة موجودة هي على أرض الواقع بشمال غرب سوريا، أنه نحن المشرفين بالمنظمات يعني أغلبنا في عنا مهام إدارية بالإضافة إلى مهامنا الإشرافية. وهذا الشيء نوعا ما بيتعارض مع أهم مبدأ بالإشراف، إنه أنت ما يكون عندك أي جانب إداري. طبعا الجوانب الإدارية الموجودة حاليا طبعا تتفاوت بين الكبيرة والصغيرة، بدءا من قبول إجازة الموظف أو المشرف عليه، إنه أحيانا بيطلب منك إجازة، فأنت مضطر أنت تعطيه القبول. فهذا نوعا ما جانب إداري ولو بسيط. أحيانا ممكن يوصل الأمر ليكون في عندنا تقييمات. هاي التقييمات يعني لها علاقة بموضوع الترقية بالعمل، بالفصل، بالاستمرار بمشاريع أخرى. بصراحة هذا الأمر يعني تعامل معه مشروع C4C بشكل تلقائي، لأنه بطبيعة الأحوال يعني المشرفين بالبرنامج ما لهم أي سلطة إدارية على المشرف عليهم، لأن المشرفين أغلبهم يعني من دول وجنسيات مختلفة، طبعا أغلبهم إسرائيليين. حتى المشرفين المحليين كانوا من منظمات أخرى، يعني جميع المشرف عليهم كانوا من منظمات مختلفة وغير المنظمة اللي بيشتغل فيها المشرف المحلي. هذا الأمر ساعد بشكل سريع بصراحة على بناء التحالف الإرشادي. أيضا أنا حرصت يعني دائما ببداية البرنامج، يعني نحن دائما يعني في عنا أو نعرف الوضع اللي بصير بشمال غرب سوريا، مثل ما تفضل الدكتور مروان من شوي، إنه البعض ما بيحب يحضر أو أحيانا ممكن يكون يعني مجبر على الحضور. فأنا بصراحة يعني طبقت معهم يعني طريقة العقد الإرشادي لجون أون رايت. طبعا هي بالأساس يعني مخصصة أو مصممة لبناء العلاقة بشكل صحيح ومهني بين المستفيد أو المنتفع ومقدم الخدمة. ولكن أنا أخذت هذه الخطوات نوعا ما و يعني كيفناها بما يتناسب مع مهام بناء التحالف الإشرافي. طبعا أنا ما طبقتها بأول جلسة ولا بثاني جلسة، لأنه نحن متعودين بشمال غرب سوريا، ويعني نحن كشعب سوري بشكل عام يعني نوعا ما من في عنا خجل شوي، إنه أنا ممكن أحضر جلسة كرمال فلان ما يزعل مني. فأنا حرصت إنه تقدم هاي، يعني طبعا بطبيعة الأحوال والزميل المشرف الإسرائيلي اللي كانت معي الآن سديان، يعني أنا حرصنا نقدم هاي الخطوات بثالث جلسة بعد ما كسبنا نوع من الثقة وبنينا شوي من العلاقة بين بعض. طبعا الخطوات هي بالأساس 5 خطوات، نحن أخذنا منها 4 خطوات. الخطوة الأولى التأكد من جاهزية المشرف عليهم. المشرف عليهم هن صاروا معنا بالجلسات إلى آخره، فنحن أعطيناهم كل الحرية والخيار. أنت هل جاي لهون غصبا عنك مشان منظمتك أجبرتك، ما حابب تحضر، أوكي تمام، بس أنت هلا حاليا لك كل الخيار إنه أنت ما تحضر. عفوا، واضح صوتي؟
واضح.
إيه نعم
كمل.
أستاذ أحمد.
تمام. هاي الخطوة الأولى، نحن أعطيناهم كامل الحرية والخيار، إنه أنت جاي هون بإرادتك لازم تكون مشان تحقيق الفائدة، حتى لو كان في نوعا ما. طبعا هذا الشيء نحن بنلاحظه بأرض الواقع، نحن في كثير جلسات أمور إلى آخره بتصير لأنه بس منظمتي هيك بدي. لا، أنت حاليا لك كل الخيار، إما بالحضور أو عدم الحضور. الأمر الثاني أو الجانب الثاني، شو أنت هدفك الحقيقي من حضور هاي الجلسات؟ طبعا هذا الأمر أخذ نقاشات طويلة، يعني شو الهدف الحقيقي من حضور هاي الجلسات؟ فكل شخص عنده أهداف معينة سواء معلنة أو غير معلنة، يعني حاب يحكيها، ناقشناها إما بشكل جماعي أو بشكل فردي. الخطوة الثالثة شفنا إنه هاي الأهداف اللي أنت عم تحكي عنها أو أنتم عم تحكوا عنها، هل هي قابلة للتحقيق؟ لأنه نحن ما بدنا يتأملوا شيء ونحن ما نكون يعني قادرين نقدم لهم إياه. هاي الأهداف اللي أنت حاطها هل هي فعلا قابلة للتحقيق؟ وهم ننتقل للخطوة الرابعة، هل نحن كمشرفين الأشخاص المؤهلين فعلا حتى نقدم لك هاي أو نحقق هاي الأهداف مع بعض؟ إذا بتعتقد طبعا ممكن يكون في بعض المشرفين إن معروفين بالنسبة للمشرف عليهم. في البعض مثلا كان البعض ممكن من منطقة قريبة من منطقتي أنا، من مكان سكني، فبيحب ما يحكي أمامي شيء. فهل أنت عندك رغبة تنتقل لمجموعة ثانية بتحسها آمنة بالنسبة لك؟ بعد ما حكينا بموضوع العقد الإرشادي لجون أون رايت، طبعا حكينا بناء التوقعات بشكل صحيح والتأكيد عليها باستمرار. هذا الشيء حافظ على مكانة التحالف الإشرافي بشكل كبير، لأنه نحن كنا دائما نأكد الإشراف ما هو تعليمي أبدا، وما الهدف منه انه ينتقل البي اس دبليو من اللي هو عامل نفسي اجتماعي لحتى يصير اخصائي نفسي. طبعا نحن اكدنا دائما انه ثلاثيه الطبيب النفسي او طبيب رأب الفجوه والعامل النفسي الاجتماعي والاخصائي النفسي هي مثل خلينا نسميها مثل لعبه حجره ورقه نقاط. ما في حدا افضل من حدا، ما في حدا يعني مهامه افضل من حدا. كل شخص يعني هي بتعني بشكل مختصر تبدل مراكز القوة والتحكم تبع من الموقف. فما في شخص أقوى، ما في شخص أفضل في جميع الأوقات وفي جميع الجهات. في بعض الأوقات ضروري تدخل الطبيب بشكل فوري. في كثير أحيانا العامل النفسي الاجتماعي هو اللي بيتدخل، هو اللي بيعمل تقييم، هو اللي بيعمل تثقيف نفسي. أحيانا في حالات كثير ما توصل للأخصائي النفسي والطبيب. فنحن كنا دائما نأكد على موضوع أهمية العامل النفسي الاجتماعي، وما ينظروا لنفسهم بنظرة يعني نوعا ما دونية عن الطبيب أو الأخصائي النفسي. أيضا حاولنا نحن دائما المهارات اللي موجودة عند كل حدا من زملائنا العمال النفسيين الاجتماعيين اللي هن بطبيعة الأحوال مشرف عليهم، نشوف وين مكان من القوة عند هدول الأشخاص، وين مكان وين في يعطي رأيه ومداخلاته بشكل كبير. طبعا حطينا نحن يعني خطة ممنهجة لحتى نستفيد من خبرة هدول الأشخاص، لحتى نحن دائما نوازن ونخلي كل شخص يكون هو خبير ومتعلم مع بعض وبشكل متتابع. وما دائما يحس حاله انه هو لا متعلم دائما، لا، انت ايضا خبير وانت دائما متعلم. صراحة ايضا نحن كمان يعني في عندنا مهام نحن كمشرفين و خلينا نسميه دوافع عند المشرف عليهم. حاولنا دائما بشكل يعني متتابع نوازن بيناتها ونطبقها، مثل وضع الأهداف المشتركة. يعني هذا الشيء بيلعب دور كثير حيوي باستقلالية المشرف عليهم. فنحن كنا دائما نفوضهم بمهمات محددة، مثلا يعني الاطمئنان على شخص محدد في حال مثلا حدوث قصف، حدوث ضرب أثناء الزلزال. فنحن نكلفهم ببعض المهام. أيضا هالشيء يلعب دور في تعزيز دافعية الإتقان عند هذول الأشخاص. فنحن كنا دائما نكلفهم بمهمات، يعني نحن أثناء مثلا شرح الحالات أو مناقشة الحالات نشوف إنه في بعض التقنيات أو المهارات مطلوبة وهن حابين يتعلموها، فنحن أكيد ما نقدم لهم إياها بشكل جاهز، لا، نكلف بعض الأشخاص بتحضير هاي التقنيات، بتحضير هاي المهارات وتقديمها، مشان يعني نرفع من الإتقان العمل بالنسبة لهم. أيضا دافع الإرادي كمان تم تنميته بشكل كبير. بصراحة يعني نحن ناقشنا موضوع قيم المشرف عليهم. ناقشنا القيم الشخصية الموجودة عند زملائنا البي اس دبليو، وحاولنا نحن دائما عملنا وشغلنا مع المستفيدين يتركز على هاي القيم، لأنه نحن مثل ما بنعرف زملاء يعني القيم السعادة الحقيقية ما هي أبدا بتحقيق الأهداف. السعادة الحقيقية هي بعيش القيم اللي نحن بنحبها اللي موجودة عندنا. على سبيل المثال نحن كمان يعني هذا المثال أيضا كان تم تقديمه بشكل كبير، بالإضافة طبعا لأمثلة أخرى. نحن ما هدفنا، يعني أنا بدي أحط هدف في حياتي إنه أنا يكون عندي دار وبيت كبير لحتى أشعر بالسعادة. ليش أنت بدك تشعر بالسعادة؟ والله مشان أعيش أهلي وأولادي وزوجتي بشكل كثير مريح ويكونوا مبسوطين. طيب، هذا الهدف خلينا نحن نحوله لقيمة. فأنت معناها عندك قيمة إنه أنت تعيش بشكل مرتب ومريح وسعيد مع أولادك وزوجتك وأهلك. طب هذه الأمور فينك أنت تعيشها بشكل يومي. مثلا إذا مشوار صغير مع أولادك بالسيارة أو حتى بالدراجة أو حتى مشي ممكن يخليك توصل لهي السعادة اللي أنت تتمنى توصل إليها. فهي القيم نحن حاولنا نعرف ونحدد القيم الموجودة عند كل شخص ونبني كل خططنا وتدخلاتنا. حتى الأمر ساعدنا كثير بموضوع العناية بالطاقم، العناية بهدول الأشخاص اللي مثلنا مثلهم، اللي تعرضوا للقصف، اللي تعرضوا للضرب، تعرضوا للزلزال، مثل ما نحن يعني تعرضنا. يعني أيضا وجود المشرف المحلي بصراحة، وهذا أنا بحكي بتجربة شخصية، حتى أنا وجودي ضمن يعني يعني بشمال غرب سوريا أعيش القصف، عشت الزلزال، أعيش الضرب باستمرار. فأنا بعرف بشكل مباشر يعني إذا صار قصف في منطقة معينة، بعرف إنه في أحد من زملائنا موجود ضمن هاي المنطقة، فأنا مباشرة بتواصل معه. مرحبا كيفك، يعني بس صار لك فرصة طمني عنك. يعني ممكن يكون هذا الأمر أفضل من جلسة أو من ساعة إشراف كاملة. في كثير جلسات صراحة ما بسميها جلسات، يعني هي عبارة عن جلسات يعني خلينا نسميها هي بسرعة، ولكن مهمة كثير كثير. في كثير أمور يعني أحيانا تواصلات كانت تصير مع المشرف عليهم في قصف وهن تحت الدرج متخبئين، فنحن عم نتواصل مع بعض لحتى يشعروا بالأمان نوعا ما، الأمان النسبي، لحتى يصيروا بأمان، ارجع أطمن عليهم بعدين. فهي فائدة وجود المشرف المحلي بصراحة، يعني هو يعني على دراية بكل شيء، دراية بطبيعة المكان، دراية بالقصر، دراية وين عم يصير بالضبط، هذول
أستاذ
الأشخاص كيف عم يعيشوا. نعم. تفضلوا.
Ustaz Ahmad, thank you so much for talking to us about the importance of the genuine connection and the genuine concern that you have for the people that you're supporting. So thank you so much. I wanted to just make sure we have some time for questions. We are already late, but who cares? I just wondered, we have some people who have put their hands up to ask questions. So perhaps I could ask them to ask their questions and the three of you can respond as you like. So Fadia, I will press the button so that you can ask your question. Can you hear us, Fadia? If you press your unmute button, you should be able to ask your question there.
السلام عليكم. السلام عليكم.
وعليكم السلام.
عليكم
هل
السلام.
عم تسمعوني؟ عم تسمعوني؟
Yes, we can hear you.
يعطيكم العافية جميعا. أنا فادية العبد الله، مشرفة مكتب زانوبيا للمرأة السورية في مدينة الباب. طبعا كنتوا عم تتحدثوا عن الجلسات اللي أنتوا قدمتوها. أنا أول مرة بسمع بهيك أمر، فحبيت أفهم من الأستاذ إنه شو هي الجلسات اللي عم تتقدم ومين هي الفئة المستهدفة بهذا الأمر، إذا أمكن الأمر طبعا.
The sessions in Northwest Syria were part of a program that ran for the last 16 months, and they just finished about 3 weeks ago. So unfortunately, that particular program is not continuing, but we are hoping to have a meeting soon where we bring together all the organizations that were involved and all the supervisors to talk about how can we keep supervision going, how can we support the organizations to keep this going. So if you would like to stay connected with us and be involved in trying to advocate for more supervision in Northwest Syria, then you are so welcome. Thank you for that question, Fadia. Did anyone else have questions, or any of the panelists want to, I guess, respond to one another? I guess I heard so much of what was presented in the presentation about genuine connection and authentic connection, as well as practical support. Dr. Marwan.
Yes, thank you very much. And it's good to see Guido sitting in your office. He's my trainer and mentor and friend. Okay, it's I think one thing is important in the supervision is to ensure that the supervisee does not consider supervision as a punishment to poor performance, because sometimes you'll find that if somebody is not doing well, the caseload is low, or some stress related, whether it's personal or work related, then they will say, okay, let's go to supervision. You need to have individual supervision or something. And that's really, it kind of defeats the purpose of the supervision, and it gives a bad image about the supervision. That's one thing. Another important lesson that we learned, if you have an external supervisor to be with you present in the local context, it's really important to have such expertise from outside. However, if you have one local person only who is providing the supervision, sometimes this is not as good quality as having two people, one from external and one from internal, such as an international expert together with somebody from within the culture itself. Not as a translator, just somebody who is trained to be a very good supervisor as well, because this will really help the supervisees to understand the value and the importance and the significance of such supervision. Thank you.
Thank you, Dr. Marwan. And this is something we heard in the interviews with the supervisees as well, that people valued the local perspective, the cultural knowledge, and the expertise of the local supervisors. And then there were also times where it was nice to have someone from outside and to have a different perspective and to have someone turn up from across the world. So yeah, both are so important. Thank you so much. Dr. Nahla or Ahmad, was there anything else you'd like to comment on?
Not from my side, Ruth.
Okay. I know we've had a long session together. It's been
ما في شيء.
Ahmad?
يعطيكم العافية.
Okay, tamam. I'm really impressed that so many of you have stayed with us online. So thank you all so much. If you would like to stay connected with us, I'll put my email in the chat. Please reach out to us. And I think, yeah, we would definitely love to stay connected with all of you and the people that we have met today, and to share that solidarity, as Dr. Nahla said, you know, the feeling among the Syrian people of the solidarity with the people of Palestine is so strong. So thank you so much for your time and for everything that you've shared today. Thank you, Dr. Marwan, for staying up till 3 in the morning. Much love, and then see you soon. Thank you.
Thanks, Max. We'll be presenting the same invitation that shared online. أهلا وسهلا بكم جميعا. Hello everyone. Good to have all of you in this stream about the critical analysis of localization in MHPSS in humanitarian setting. This is Salah Ad-Din Ligay. I'm a psychologist. I will be facilitating this session, and after my colleague Mike, I will be presenting my presentation. First of all, thanks for everyone for being here.
شكرا لكم جميعا. شكرا مايك بالتنظيم وإلى آخره.
With you from Gaziantep in Turkey, and majority of colleagues I think in Northwest Syria and other and maybe in Turkey and other places. So our first speakers is my colleague Michael McGrath. He's a PhD candidate in discipline of psychiatry and mental health at the University of New South Wales, UNSW. He has experience working in mental health research with populations affected by conflict and displacement in Bosnia, Turkey, Syria, and Uganda. His PhD takes a health system perspective and explores the role of local and national actors in strengthening
mental health services in humanitarian setting. Mike will talk for 10 minutes about international implementation of localization and how can have meaningful benefit for local organization. He will review the evidence on the ways that localization can shift the burden onto local organization without giving them funding, decision-making power or resources in return. Mike, are you ready?
I am. Thank you, Salah.
Welcome, Mike. We can see your presentation.
You can see everything? Perfect.
And your voice is clear. You can make it more louder a little bit, please.
Okay. Hello, welcome everyone. Thank you for the introduction, Salah. Today I'll be presenting the results of a scoping review examining localization within humanitarian health response for populations affected by conflict and displacement. I understand that the term localization is probably not familiar to everyone. So I'm going to start by providing a background to the concept, and then we'll define it, and then move on to the findings of the review. So to provide that background, localization became a priority in the humanitarian system following the Grand Bargain Agreement made at the World Humanitarian Summit in Istanbul in 2016. The Grand Bargain Agreement was signed by 48 international actors who collectively control over 95% of the world's humanitarian funding. And localization was promoted as an essential reform of the humanitarian system. There was an international consensus that we needed to improve the humanitarian system, in particular in terms of its effectiveness, efficiency, legitimacy, and inclusivity. So why were these reforms necessary? The humanitarian system has been dominated historically by a network of donors, states, and international NGOs from the global north and centered around the United Nations system. And these actors control resources, they decide priorities, and they establish humanitarian principles and norms. And so in this respect, the humanitarian system has reproduced colonial legacies, and it marginalizes humanitarian actors from the global south, excluding them from funding opportunities and ignoring their knowledge and experiences, the knowledge and experiences of affected communities. The Grand Bargain sought to recognize the diversity of international actors involved in humanitarian systems. And this included both national responders, so people like ministries of health or municipal health services, as well as local responders, so NGOs, religious organizations, or refugee-led organizations. Here's the objectives and priorities agreed to at the World Humanitarian Summit. At the top, the overall objective was simply better humanitarian outcomes for affected populations. And this was to be achieved by acting on two priorities. The first priority was better funding, but priority two, which is in the red box, this is the localization priority. And this was a commitment that greater support is provided for the leadership, delivery, and capacity of local responders, and the participation of affected communities in humanitarian response. But despite all this increased attention on localization, the term remains poorly defined. I've put three definitions here just to sort of introduce the term. The first one, Barbalet highlights the need to recognize, respect, strengthen, and return ownership to local and national actors, while Guyet emphasizes the need to put local and national organizations at the center of decision-making about resources, about investment, and about how we prepare and respond to humanitarian crises. But I actually just like this third definition here by Alnap, and it simply says that localization is recognizing the power and the capability of locally led action and divesting power and resources to it. And despite this priority of localization in the humanitarian system, very little is known about progress towards the goals of localization or how localization happens in practice. So we aim to conduct a scoping review, and we wanted to identify the challenges, successes, and outcomes of locally led humanitarian health response for populations affected by conflict and displacement. To do this, we systematically reviewed 7 academic databases, and we wanted to find studies describing localized or locally led humanitarian response. And we kept this definition as broad as possible to capture all possible local actors. Like I mentioned earlier, it could be government action, local NGOs, diaspora organizations, religious or faith-based groups, and the community itself. We wanted papers to focus on the health system. So that was any form of health funding, organizations, healthcare workers. And we focused on populations affected by conflict and displacement in low and middle income countries since 2016, which is when the Grand Bargain was signed. So some results. We identified just over 2,000 records from 7 academic databases, of which there were 1,044 unique studies, which we titled and abstract screened. And in total, we found 43 studies to include in the review. They were mainly qualitative or mixed method studies, with just 3 quantitative studies. Here's a map just to represent the geographical sort of range of the studies we found. Of the 43 studies, 13 describe humanitarian response for displaced Syrians, both in Northwest Syria and in neighboring countries of Turkey, Lebanon, and Jordan. The next most important crises in terms of the number of studies we found were displaced people from Myanmar, in Bangladesh, and Malaysia, which we found 5 studies on, and also displaced South Sudanese people in South Sudan, Uganda, and Kenya. There were also 5 studies from there. I just now wanted to talk through sort of 4 key findings from the review. The first one is around local leadership. So opportunities for local leadership were undermined by a number of factors. The capacity of local organizations and local health systems had been undermined by the conflict, and the displacement of healthcare workers, managers, specialists, and policymakers. In Syria, healthcare workers faced challenges gaining professional accreditation, in particular in Northwest Syria, while in host countries, displaced Syrian healthcare workers were not always legally entitled to work and therefore excluded from leadership roles. We found evidence that state actors targeted NGOs and civil society organizations. Therefore, refugee-led organizations relied on informal networks, and they operated as these small, low-profile organizations. And this usually meant they were subcontracted to international organizations. And as a result, they weren't always able to take leadership or governance positions. And then finally, international actors didn't trust local actors, in particular around adhering to humanitarian principles. They thought they were too close to the conflict, and as a result, excluded them from leadership opportunities. In terms of health service delivery, local and national organizations were recognized for their crucial role that they played. And there were many studies that describe partnerships and collaborations between international and local organizations. And international organizations justified these partnerships because their local partners could improve service access and reach in conflict zones, and they could provide services often to these hidden refugee populations. And this was because local actors were close to the affected population in terms of geography, but also in terms of shared language and culture, and often a lived experience of displacement. And in the case of refugee-led organizations, the local actors were of the affected community. And so as a result, these local actors were seen as more legitimate and trustworthy by the affected population, and they were able to provide services that better suited the context, as well as services that responded to the priorities and the values and the needs of the population. But this improved access and reach that was achieved by locally led humanitarian response also exposed local healthcare workers to greater safety and security risks. So we found many examples of local health workers detained, assassinated, or abducted. This was sometimes due to local staff being targeted specifically by state actors, and it was exacerbated by an increase in remote management structures in the humanitarian system, where local staff operate in the most dangerous contexts and international staffs remotely manage projects from abroad. Safety and security concerns were compounded by a sense of loyalty or obligation among the local staff to their communities. So Syrian healthcare workers described themselves as the sons of the country, and they were deeply committed to continue working in the most difficult circumstances.
Mike, another 2 minutes.
Thanks. And so despite having medical qualifications and visas to leave the country, many continued to provide services to their community due to moral or religious or patriotic obligations. And while these obligations might have improved the stability and the continuity of service delivery, they also put the local healthcare workers at risk of burnout, in particular because unlike large international agencies, local organizations were unable to provide or offer support programs to their staff. And we also found examples of international organizations poaching local staff by offering better salaries or conditions or longer contracts. And then finally, the fourth sort of theme was one of financing. So in terms of financing, localization typically involved subcontracting or inequitable partnerships that was still led by international actors. So international donors were described as being risk averse and providing restricted funding or short-term project-based funding. And this limited opportunities for local leadership, for development of staff, and for capacity building. These restrictions were often related to the collapse of banking systems or government structures, where international funders were particularly concerned about corruption or diverting funds to parties in the conflict. And so local partners described an audit culture or inflexible bureaucratic arrangements where they had to focus more on financial management and donor compliance than on service delivery. And this was particularly problematic for refugee-led organizations, which were often too small to meet these administrative and governance requirements. So in conclusion, despite all the attention localization has received in the humanitarian system, our review identified few examples of meaningful transfer of power, decision-making, or resources to local responders. While local responders were valued by international partners because of their efficient ways of implementing services or programs, within the humanitarian system, local actors remained on the bottom rung of the ladder. They were restricted to on-the-ground roles, and they were excluded from leadership, decision-making, and a lot of capacity-building initiatives. And so this aligns with commentary from Eleanor Fidian-Kazmier, who noted in the lead up to the Grand Bargain Agreement that the localization agenda may be a way for northern states to shift responsibility onto southern actors or to simply withdraw from international responsibilities without sharing the promised funding or resources. I'll hand back to you now, Salah.
Thanks, Mike. Yes, thanks for this valuable presentation about localization. If two of our respectful participants have questions, please, this is the time of questions. You can write it down on the Q&A box or raise your hand, then our colleague Max will open the speaker for you. The mic, sorry. I think there is no questions so far. إذا في أسئلة يا جماعة تحبوا تسألوا على مايك سؤال واحد على الأقل. Okay. Thanks again, Mike. Our next presentation, it will be from myself. And this is Salahuddin Ligli. I'm Syrian psychologist, certified supervisor, and a member of the C4C research. It's not easy to talk about yourself. Okay, Salah has experience in the Syrian context for more than a decade, providing MHPSS as a practitioners in Syria, Lebanon, Turkey, and Northwest Syria. He's also a practitioner in CBT and narrative exposure therapy. His primary focus on community and cultural-based MHPSS interventions, including gap, group interventions, and supportive and supervision within the Syrian context. I will share the presentation. Can you see my screen right now?
Yes, we can, Salah.
Okay, thanks, Mike. Is the interpretation is good right now? I will be presenting as something about analysis of how contextual factors affect implementation of MHPSS in Northwest Syria. We try to answer the question, what is needed for effective local control of MHPSS, mental health and psychosocial support in Northwest Syria? First of all, what the meaning of context? Context refers to the unique circumstances, conditions, and factors surrounding a project implementation site, including sociocultural, political, economics, and environmental, and other elements. In this analysis, we're using the context and implementation of complex interventions framework. It's well known as CC or KIKI framework. The context and implementation of complex interventions, KIKI framework, is a comprehensive tool designed to enhance our understanding of how complex interventions function within a specific context. This developed by researchers. It addressed the interplay between context, implementation, and the interventions itself. Here is the elements of KIKI framework. As you can see here, there is 7 main domains of context: geographical, epidemiological, sociocultural, socioeconomics, ethical context, legal, and political context. And there is 2 different, let's say, level of this framework. One of them, they call it the implementation. Okay. Is there any problem with the presentation? Yeah. It's stuck. And now? It's okay? Thanks, Ahmed. So I was explaining the 3 levels of KIKI model. There's 7 elements of context we already mentioned. There's another level, which is the implementation theory. And there is 3, let's say, domains or elements: the intervention itself, the implementation agents, the implementation strategy. And there is the 3rd level of, let's say, the KIKI model, which is the setting. It means when we deliver or implement the interventions, and there is service providers and there is service users in that setting, in that time. So we use this framework to analyze the stakeholders focus group discussions that conducted last year in Northwest Syria and in Turkey. Because we are talking about the context, of course, we should be specified. So we are talking about the Syrian Arab Republic, but especially about the Northwest Syria, when we have almost 5 million population living in this land, in this corner of Syria, which is very close to Turkish borders. As I mentioned last year, we conduct stakeholders focus group discussions, and the main goal or questions that this initiative seeks to address are the key areas of improvement to strengthening. Sorry.
شو المشكلة؟
Is it just from the interpreter or everyone?
لا حتى بعت لي شو
اسمه. Okay. Sorry, Max. Can you see my screen right now?
Yeah. It seems that your when you change slides, it doesn't come through every time. It sort of stops. If you just change slides
Is it okay?
manually,
Yeah.
Okay.
as you go.
I will do the same every time. Okay. Okay. So the main question that this initiative seeks to address are how can we improve strengthening ethical provision of mental health services, and the key areas of improvement to promote the well-being of service providers. Thirdly, the role of supervision in strengthening ethical provision of mental health and promoting the well-being of service provider. Okay. Our data analysis, as I mentioned, by using the Kiki model framework, and we try to identify the relationship between Kiki domains and across the three levels of this framework, in addition to add the macro, meso, and micro level, which is meaning the general, let's say, environments or general, let's say, components that affect the implementation. The middle, let's say, level, which is meso, and the micro, it's related to the organization or the service itself or the clinic, MHPSS clinic, etc. Of course, we're using more than one method, but it's not our priority right now. Therefore, I will go to the result of this analysis. The stakeholders' opinion in the focus group discussions. Sorry for this. So the result of stakeholders' opinion in the focus group discussions corresponded to the majority of the Kiki framework, the 7 Kiki framework domain, especially political, legal, epidemiological, sociocultural, socioeconomic, and geographical. Within each of these domains, specific themes surfaced in the focus group discussion, which are referred to sub-domains of the context. Within each of subdomains, we differentiate between the challenges and what should be addressed in mental health sectors from the stakeholders' perspective. Okay. In summary, Northwest Syria and contextual determination of problems in mental health care interacted across macro and meso and micro contextual level, contributing to mental health legislation, assessment of community needs and designing the interventions to address them, support for staff in both training, supervision, and staff care activities, standardized target of services to be achieved by MHPSS workers, relationships between staff in international and local NGOs, the needs of mental health patients in both specialized interventions and medications. Okay, last 3 slides. And regarding to designing and implementation of MHPS interventions, according to Kiki framework and the perspective of stakeholders, what should anyone would like to conduct interventions, MHPSS intervention in Northwest Syria or Syrian context? First of all, improve coordination between health partners and non-health actors in order to expand the scope of MHPSS response and address the equitable availability of resources in the region, complementary in the work and sufficient coordination between sectors, relationships between international organizations and local NGOs should be more, let's say, addressed. Gaps in the level of design and the preparation of mental health projects need to be addressed also. In the designing phase, sometimes it looks like there is no involvement of mental health specialists. Standardization indicators of mental health and psychosocial support can be approved by the mental health technical working groups and other actors. And regarding to political context subdomains, the local authority in context and association need to be more involved. The role of local authority in the region and the role of oversight community representative to be involved in terms of organizing, planning, and managing mental health project that depends on valuable resources and build on needs. Standard that regulate practice in the community, being involved in assessing context and responding to this in designing the interventions, designing the projects and making it fit for the community. Finally, relationships with international organization and local. Finally, on legal context subdomain, there is lack of legislation and licensing for the MHPSS professionals and workers. This should be addressed, and no one other the local authority and community actors and association in Syrian context can develop and let's say come up with those legislations, mentoring and compliance with laws and regulations and regarding to implementation of mental health intervention in Syrian context. Thanks for your listening. That is everything from my side. If you have any question regarding to this presentation, I will be happy to answer. Okay. Our third speaker, if there is no question, we will go to Dr. Faiz. Okay, so our third speaker is Dr. Faiz
Hamid.
Can you hear me?
Faiz Hamid.
Yes, I know that, Dr. Faiz. Can you hear my voice?
Sorry, do you hear me? Salah.
Is everything well? Can you hear me? Yes, I can hear you.
I can't hear you very well. I don't know why.
Okay, Max, is everything well for interpretation and my voice?
I think so, yes. I can hear you clearly.
Thanks. I will introduce you, Dr. Faiz. Just give me 1 minute. Thanks for being here. So our third speaker is Dr. Faiz Mahamid. He's an associate professor in clinical mental health.
مساعد فيما يتعلق بالطب السريري والاستشارة.
Najaf National University in undergraduate and graduate mental health program. Dr. Muhammad supervised several projects in the field of mental health, group and an individual. And he also served as a head of psychology department and vice dean of the Graduate School of Human Science in An-Najah University. His research focus on investigating throughout a mixed method research design domains and dimensions of well-being in war-affected populations, therapeutic interventions, trauma interventions, mental health, internet addiction, clinical supervision, and alcohol counseling. So Dr. Faiz, please, he will talk about the Palestinian experience regarding mental health under occupation. You are welcome, Dr. Faiz, please.
Thank you very much, dear Salah, and thank you for everybody here. And I'd like really to thank our colleagues at Sydney University and our colleagues at Milano Bicocca University. In particular, my colleague
بشكل خاص دبرونوسيا ودكتور روس أيضا من جامعة سيدني لهذه الدورة.
to introduce mental health actually conditions within the Palestinian context. Let me first of all, let me share my slides.
It's okay like that. Yes.
Yeah. So I'd like really, first of all, to introduce the Israeli-Palestinian conflict briefly, as all of you know that this conflict began almost before 76 years. And when the first war between Arabian countries and Israel occurred, and this war ended up with the establishment of State of Israel. In 1947, Israel totally occupied more than 78% of historical Palestine, almost 3/4 of the British Mandate of Palestine. And in 1967, Israel totally occupied the whole Palestinian lands. And from that moment, since that time till present, Palestinians suffer from several types of actually psychological and social problems. As I mentioned, the 1948 war ended up with 700,000 of Palestinians who became refugees in 3 neighborhood countries, Jordan, Lebanon, and Syria. And the Palestinian suffering and the ongoing oppression continued from that moment to this time to the present. Actually, as I indicated, in 1967, the Israeli army occupied the West Bank, the 1967 region. This includes the West Bank of Palestine, the Gaza Strip, and East Jerusalem, and resulting in a second Palestinian exodus. With 500,000 of Palestinian people became internally displaced into 16 Palestinian refugee camps in the West Bank of Palestine and the Gaza Strip, and also to Jordan. This is just a brief introduction on the Israeli-Palestinian conflict from a historical perspective. Several research conducted within the Palestinian context indicated that Palestinian people suffer from several types of psychosocial disorders, mainly from PTSD, collective trauma, distress, depression due to the Israeli occupation. It means that the Israeli occupation affected negatively the lives of Palestinian people and all aspects of life in Palestine. The current diagram actually clarifying the 14 years of childhood in Gaza. As you see, children at age 14, they may experienced and witnessed 4 wars in the Gaza Strip. It's really worth it to say that the word post-traumatic is not existed in the Palestinian dictionary, as trauma within the Palestinian context is continuous, repetitive, and ongoing. And as I said, that people or children, particularly in the Palestinian context, suffer from several types of traumatic experiences. And on the last war on the Gaza Strip, more than half of victims, they were from children. Unfortunately, they were from children. In Palestine, the home demolition policy also actually threatened seriously mental health of Palestinian people, and it found to create like fear, sense of humiliation and anxiety and hopelessness, particularly among Palestinian mothers who try to protect their children. So the home demolition policy affected also negatively all aspects of mental health among Palestinian people in the West Bank of Palestine and in the Gaza Strip, and even in the East Jerusalem, as several cases were documented, several cases of home demolition were documented by international institutions. The lack of safety, protection, and also stability in Palestine contribute also to suffering, as environment in Palestine is insecure and unpredictable. So people try to deal with constant threats and actually threat to their homes, a threat to their lives and family survival. Another thing which is really it's important to be mentioned, that collective identity trauma operation was found to be highest trauma occurrence among Palestinians in Gaza Strip and in the West Bank. And several studies within the Palestinian context indicated that collective trauma operation negatively predicted mental health outcomes in terms of distress and anxiety and stress. Several studies were conducted also within the Palestinian context, really indicated that trauma could be transferred over generations via narratives, via stories, as many studies were implemented here in Palestine. The main findings of these studies revealed that Palestinian people, mainly Palestinians who live in internally displaced camps in the West Bank of Palestine, they suffer from collective trauma. It means that this is related to collective unconscious of the Palestinian people, that trauma may transfer from the third generation of Palestinian refugees to the second generation till the third generation of Palestinian people. When we say collective trauma, this is related to the first actually Palestinian catastrophe, al-Nakba. So the effect of Nakba really not only affected the third generation of Palestinian people, it may also affected several generations of Palestinians who live in the West Bank of Palestine, and particularly people who live in internally displaced camps in Palestine. Actually, the quality of life is in Palestine was reported among the lowest, the worst quality of life in the world. And we talk here about all dimensions of the quality of life, the environmental dimension, physical and psychological dimensions. So people live under very poor quality of life, very poor living conditions. And as I said, it was classified among the poorest quality of life in the world. Another thing, actually, Palestinian youth reported emotional and helplessness, suffer several actually types of psychological disorders and problems. And most of them, they are leaving schools to work due to poverty and to fund themselves and their families, and which is really embedding the continuity of higher education among Palestinian people or Palestinian children. And as I said, poor living conditions related directly to the Israeli occupation or to the West Bank and the Gaza Strip. And people are suffering because of this occupation. Another thing which is really it's need to be mentioned here, like sense of humiliation. Humiliation is widespread spread in war settings, so or in conflict settings. Palestinians experienced humiliation in a collective and an individual manner. As I said, they witnessed, they experienced several types of political violence. This includes being shot, being hit, or kicked by Israeli soldiers or settlements. And several studies within the Palestinian context indicated that sense of humiliation negatively predicted mental health outcomes, quality of life, and well-being. So it's really important to take this into consideration when we discuss the mental health issues within the Palestinian context, that Palestinians suffer from high level of humiliation due to the Israeli practices and policies. And you can see here on the last word of This is an example of emulation on the last war on Gaza Strip. You can see that this picture may explain this concept very well. Also, I just try to finalize my presentation by saying that mental health services within the Palestinian context should be understood or should be reframed contextually. There is a need to focus on international values of freedom, social actually self-determination, and also social well-being, maybe human rights, as the advancement in human rights linked to the advancement of mental health generally. So thank you very much for your listening. I tried to introduce briefly the mental health situation in Palestine related to Israeli occupation. Thank you very much.
Thanks, Dr. Faiz. We appreciate this narrative about Palestinian rights. We totally agree that there is injustice nowadays in Palestine, in Gaza, in Syria, in more than country, in Middle East and others. However, being here is sending a message. How can we support each other? Solidarity against injustice and occupations. I would like to thank again Mike Grath for his valuable presentation about the localization, and Dr. Faiz about the Palestinian experience in MHPSS interventions under occupation. And of course, my colleagues in Hope Revival for the presentation regarding to Northwest Syria, and let's say recommendation regarding to localization of mental health. If anyone have a question for Mike about the international, let's say, perspective, how to make MHPSS local, our colleagues in Palestine and their experience in providing MHPSS, or something about the Syrian context regarding to MHPSS recommendation. We have more than, let's say, 2 or 3 minutes. If any question regarding to those topics, we will be happy to answer, me, Dr. Faiz, and Mike. في ترجمة معك؟ Okay. If I would like to ask both of you, Mike and Dr. Faiz, what is the main, let's say, recommendation from your own experience? What the first thing came to your mind when I ask you, how can we implement mental health interventions in such context? I need to hear from Dr. Faiz's perspective and also from Mike's perspective, especially in our context in Palestine, in Syria, in other countries. Dr. Faiz, if you'd like to start.
Yeah, thank you very much, Salah. I think that really improving clinical supervision within the Palestinian context is needed, as you know, healthcare providers here within the Palestinian context are suffering too. So there is a need to, let me say, activate academic preparation, clinical supervision for staff members who actually work on frontiers and work in special regions like such as Palestine. It's really important to support staff members and to actually give them like feedback regarding their work, to give them like psychosocial also services, to offer community support for mental health services within the Palestinian context specifically. And actually, healthcare providers here in Palestine really take high level of responsibilities, as they are themselves traumatized. They are themselves suffer from several psychological stressors. So there is a need to activate, to improve clinical supervision. As you know, supervision usually from the international perspective includes consultations, assessment, support, and psychological intervention for staff members.
Yes.
There is a need to train members and to activate actually the institutions, maybe NGOs, formal body here in Palestine, Ministry of Health, all of them should work together to support healthcare providers who work intensively with several cases of trauma, collective trauma, and complex trauma, and ongoing traumatic experiences. As I said, the word post is not existed in the Palestinian, within the Palestinian dictionary, as trauma is continuous. So the main criteria of diagnosis also should be reframed. I'm talking about trauma here. We should reframe this and reframe the interventions to be capable, to be suitable for the uniqueness of the Palestinian society. Thank you.
I see. Thanks, Dr. Faiz. There is another question came to Mike. Mike, there is a question in the chat. Our colleague, I think, Gabriella, asking Mike, I was wondering if you could tell us a bit more about why localization is not implemented, how it was meant. What are the underlying issue preventing INGOs, international NGOs, from actually sharing resources and power?
Yeah, thank you, Gabriella. I think the most important issue we see across different settings and different parts of the health system is trust. It's a really important thing for local organizations because they have the trust of the local community. They have and they're seen as legitimate and they're connected to the community. And so they have this great access to populations and they can provide services that are perhaps more culturally appropriate or better for the context. But on the other side, on the other hand, these local actors don't have the trust of international actors. The international actors were often describing partial or incomplete localization. They would only go so far. So they would give some decision-making or some little bits of control to these local actors, but they would never trust them with budgets or with long-term contracts or enough funding to provide sustainable services, capacity building, and enough money in the long term so that local actors can become the leaders and to take real decision-making power.
Yes, thanks, Mike, and thanks, Dr. Faiz, and thanks for everyone here. I can see Dr. Mishteld. She's one of our hero in supervision in Syrian context. She's from Germany. She was the leader of supervision program for 4 years. So welcome, Dr. Mishteld. We are very happy to have you also. If you'd like to comment about your experience in Syrian context regarding to supervision, this will be add value, and thanks again.
Yeah, thank you. I'm so happy to see you. It's just great. And I, as an international from Germany here in Potsdam, sitting in beautiful Potsdam, I'm often asking myself, what can we do to be really of support for the local services and not being a burden to them and destroying structures that they might establish themselves. I think it's a very ambiguous situation. And okay, we had the good thing was that we had these long-term trainings of 2 years. So I mean, we were able to raise capacity and supervision from local staff inside Syria and from Turkish staff. So yeah, and of course, confronted with such a difficult situation in Palestine now, we are watching it and saying, okay, what could we do from the international side? Tonight I will have a call with the European Association of Supervision. We have an international working group, but yeah, we don't know how could we be of support. Would it make sense, like as Australia did, as Roosevelt and so on, the colleagues did, they had this opportunity for supervision for people. yeah, if you just have any ideas what I can take to the colleagues, how they could be useful for you, I would very happy to hear.
Thanks again, Dr. Michel. Thanks for your comments and for being here and for everything you are doing in the last, I think, 4 years in Syrian context regarding supervision and preparing almost 40 Syrian supervisors, certified Syrian supervisor. Every 20 of them received 2 years of supervision, program supervision, which is great opportunity to prepare supervisor. I was lucky to be one of those people receiving 2 years of supervision. So thanks again. If anyone have any comment or question, I think there is comments on the chat box. Thanks, Ahmed. Thanks, Gabriella. So from my, I would like to say that I'm very happy to have all of you here, to hear from you, to share this experience. How can we enhance our MHPSS interventions? In this stream, we're listening to Mike's perspective and experience in working in localization as a researcher, and he has wide experience in these topics. And also we listen from Dr. Faiz and Hamid. And thanks again, Dr. Faiz, for sharing your experience and your recommendations and your resistance against occupation, and to provide to the population their own their basic needs and get the health service and mental health services. And we highlight about our experience in Northwest Syria regarding to the C4C research and providing supervision in the last 2 years, and also the recommendation regarding how to implement, let's say, local and valuable and effective MHPSS intervention in Syrian context. This is the final, let's say, stream from the webinars today. I think we done today, and thanks again for everyone. I would like to ask Max if there is another recommendation from your side. And thanks for Max and everyone and the interpreters here who provide us with Arabic and English interpretation.
Yeah, so that is the final part of the stream, but we will return to the original webinar link so that we can have things finalized by Ruth. They are not quite finished, but I will post the link in the chat. Thank you so much for attending, everyone.
Okay, so we will use this link to go back to the main session or webinar.
Correct.
Okay. Thanks a lot. See you there.
I will
Bye-bye.
end the meeting now.
Back to the main room.